It's a matter of great privilege that BOA is starting a new PG competitive session under the name of Professor Dr. Bashir Alam. He was the HOD of Patna Medical College for more than a decade, I think 10 years and few days. And a lot of things I wanted to tell him because I did my post-graduation from under him. And it was indeed to learn a lot from him. Those the new students may not be knowing well about him, but about the punctuality, you can just set your clock. While he was coming to the department, so you can set your clock exactly 9 o'clock he used to come. So I still remember that. And under the guidance of him, Patna Medical College had achieved very new heights, and his focus was definitely the emergency and the passion about with the patient, and with his humble nature. It was indeed a lot to learn from him. So BOA is really very proud, and it's a real privilege for the BOA that we are starting the PG competitive paper, which is a very prestigious one for any conference, because the postgraduate students really they learn how to speak, how to deliver their lectures from this stage only. So this is the platform where you really learn how to make papers, how to deliver lectures, and then you proceed to your final destination throughout in your career. So it's a really very, very prestigious session. So before starting, I will request Dr. Bashir Alam sir, Dr. S.H. Jha sir, and our past president, Dr. Bharat sir, and Dr. Anil sir, and Dr. A.K. Manav sir. So please come to the dais and do the lighting of the lamps.
सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Thank you everyone, and this time there is a huge response from the postgraduate students, and this is the first time in the history of BOA that 43 PG papers has come. So it's really, really great. So all the medical colleges of Bihar, they are participating in a big way. It's a very good sign that you are participating, and now the National Medical Council has drafted a rule also for you that you have to present one paper and one poster in your whole career of 3 years. So that's wonderful. So today our judge will be Dr. Bharat sir, and I think Dr. A.K. Singh will be coming. And before that, I will request Professor S.S. Jha to come and say a few words.
Professor Bashir Alam, Professor Bharat Singh, Professor Manav, Professor Rajiv, Dr. Arun, all the members of the Nalanda Orthopedic Club, and most importantly, all the postgraduates who are participating. Friends, it's with very great difficulty that a milestone is created. Today is an important day that this PG competitive session has been named after a person who is not a common sight today, because the values, the perceptions with which you want to grow belongs to Professor Bashir Alam in ample quantity. So, the first thing that it has been named after him will go a long way. Now, as Professor Rajiv was saying, that this PG competitive paper has attracted so many research papers. I am so very happy because I can remember when I thought that in Patna there should be a city orthopedic club, and then we thought that it should be there in all these important cities of the state, at least where medical college exists. So Patna City Orthopedic Club also has gone a long way. But that was the time when I used to think that if one has to chair a session, there is dearth of persons. But with passage of time, there is no dearth of persons, I am very happy to say. And every year in the Indian Orthopedic Association conferences, we are chairing the session, we are participating too. Few points for presentation I would always like to say. Number one, being a postgraduate, you are really little shy. Don't be shy. So speak out, and speak out loudly so that you are audible. People will be able to judge you only when you are audible. So you should be audible, not hyper audible too. Number two, always remain within the tight framework of the time schedule. Because once when you are here with a paper, you are ready with so much of material. You can't say everything in your presentation. So have only 6 slides. And also in those slides, let it not be 20 lines in a slide. Not more than 5 to 6 lines should be there. And that should carry a message in the end, the take-home message. I am reminded there was an IOA conference in Goa. Professor J.S. Makhani, who is no more, was the head of the department in Goa. And he said, I have brought you to Goa not only for scientific session, I want you to visit places. So what he did, he gave only 2 minutes for each paper presentation. First half there used to be paper presentation, 2 minutes each. He said just say the message. And second half buses were queue and people used to visit. This also is a similar place where there are many places to visit. So kindly remain to the framework of an ideal presentation. Thank you Rajesh, thank you very much.
Thank you very much, sir, for your kind words and the tips to the students for preparing their papers. So I request all the students who has come over here, kindly load your presentation quickly. Only three has loaded now, only 2. So quickly load it because there won't be time. So now I request Dr. Professor Bashir Alam sir to please come and say a few words to our budding students, the future orthopedic surgeons.
First of all, I must thank all our colleagues who have honored me by dealing with this scientific session, as you told us, here, what Dr. Shah has told you, dicts of paper presentation, so that you may get very good exposure in a very short time. So it is better to give a good exposure in a very short time than to elaborate. And I request all my junior colleagues and PG to take part in a large number in such a research work. And I again thank my colleagues to name this postgraduate paper in my name for the golden presentation of the paper of test paper. Thank you.
Thank you, sir. Please give a standing ovation for Professor Dr. Basim Alam, sir, ex-head of the Department of Medical College.
Narendra ji, thank you very much for all the leadership qualities that you have. So,
So formally we will start the competitive session, PG competitive session now. And may I request Dr. A.K. Manav sir, Professor A.K. Manav sir, and Dr. Bharat Singh sir, HOD PMCH, to please come and take the chair in the dais to judge the papers of the postgraduates.
who is ready? Dr. Vaibhav Sanjay is ready? Yes, come on with us.
Good morning, respected teachers and my seniors. Today I am going to present a paper on recurrence of joint cell tumor in fibular graft after resection of distal and radius GCT, a case report. Presentation was a 31-year-old female presented in our OPD in 2017 with pain and swelling in left distal forearm or wrist and inability to work with left hand for 6 months. Pain was insidious in onset and it was gradually progressive in nature. Severity was increased over month, but the pain was relieved after taking analgesics. The swelling was 5 to 3 cm over distal radius, bony hard, fixed and well defined. Margin was irregular surface, overlying skin was mobile, local temperature was normal and distal neurovascular structures were intact. So I investigate the patient. On doing the blood investigation, I have ruled out that there was no increase in ESR and CRP, and infection was ruled out, and X-ray shows eccentric lesion, and on MRI it was localized. We have done the bone scan, and there was no distal skip metastasis found in this case. We confirmed our diagnosis by doing a true-cut biopsy, which was suggestive of giant cell tumor. We diagnosed this case as a localized giant cell tumor, left distal radius, without neurovascular invasion and distant metastasis. And grading based on the Campinasi grade, it belongs to grade 3. Treatment option, I have demonstrated one video of extended curettage of the distal tibia. This is showing with the help of high speed bulb. We have done the mechanical, and this is with the carbolic acid. We have done the chemical curettage. This is another video of distal radius which shows translocation of ulna and centralization of wrist. In this case, we planned for ipsilateral fibular grafting and reconstruction of the distal end radius. First, we take the Boacon incision and we remove the tumor mass. We resected the tumor and send it for histopathological examination. We have grafted the proximal fibula by without endangering the common peroneal nerve, and this is the CR picture. And post-operatively, these are the graft harvested from ipsilateral proximal fibula with wrist reconstruction with ipsilateral fibula. But unfortunately, in 2 years, we have on regular follow-up. After 2 years post-op, patient again complain of pain and swelling of distal radius with restriction of movement reappear. We have done the X-ray and bone scan was done. In this case, to rule out the recurrence and metastasis, we have done the CECT thorax also, and biopsy was planned. In this case, we can see there was cortical breach present on the X-ray. We have done the bone scan, but the lesion was still localized on the ipsilateral fibular graft side. There was no distant skip metastasis found. We have done the histopathological report, and this is the histopathological slide showing that there was recurrence in fibular graft with Jaffe grading 2, which shows Jaffe grading tells about the number of mitotic body and chances of recurrence in the case of fibular graft. So the treatment option for recurrent distal end radius was again on the same basis that Campinasi grade 1-2, it was grade 3. So we planned for, there was centralization of ulna or fibular graft. Ultimately, on the basis of this, we planned our procedure for the removal of implant, followed by excisional biopsy of previously grafted fibula and ulnar osteotomy and translocation of distal ulna to dorsal approach. But during the removal of the tumor, there was injury of radial artery, and our plan is shift to centralization of wrist joint and wrist arthrodesis. This is the intra-op pictures showing the resected fibula, and we have done the centralization of wrist. This is the post-op X-ray, and the patient is currently doing well. And our conclusion from this and take-home message was the treatment of this complication is always a resection of tumor with centralization of carpus with wrist arthrodesis or below elbow amputation. To retain the function of otherwise normal hand, centralization of wrist joint and wrist arthrodesis is a good option. We have done the CT angiography to check for both the arteries compatible, that is radial as well as ulnar. In our case, it was compatible, so we went for centralization of ulnar. This is taken from this is a published journal in our association. Thank you.
Well, do you think that removal de novo had some problem? Did you go for extra periosteal resection of the tumor, or you went inside the periosteum?
So we went for extra periosteal removal of the tumor, and after the removal of the tumor, we have cleared the tumor bed and muscles also be removed. We tried to remove all the tumor, but because we have seen with the naked eye, we don't have the capability of microscope and further section. So as far as
so all precautions taken, you had done.
yes.
So why did you do the MRI before surgery to see the any soft tissue invasion?
Sir, we have done the MRI initially also. At that time, it was extension was there in the soft tissue, but it was localized in the distal end radius only, not apart from not any other side. So we precaution of margins was also taken, but again, sir, there was.
When you have taken the MRI and there is a soft tissue invasion, what does it suggest?
Sir, if there is soft tissue extension at the local site because of cortical breach, it is Campaniaceae grade 3, it was localized lesion with,
Localized alignment or?
sir, malignant, sir. Yes,
When it is in reddened soft tissue,
yes, sir.
then it is not localized and the cause of recurrence is the invasion of the soft tissue.
Yes, sir.
Yes.
Yes, sir.
For that things, what will do?
Sir, for that thing, we nearby soft tissue was removed as much as possible, and it was also with the help of hydrogen peroxide, it was washed at that time. But sir, after doing these all things, then also there is a recurrence.
The other options except orthodesis?
Sir, other option is centralization of ulna over the translocation of ulna, or we have, or we could have gone for, in this case we have gone for ipsilateral fibular
For
grafting.
orthodesis?
Yes, sir.
Other option?
Centralization of translocation of ulna, single bone rest.
And ipsilateral fibula you will take upside down.
Yes, sir.
And then it has recurred again.
Then it has recurred. So the first option we have repaired.
Any idea for custom-made prosthesis replacement?
Yes, sir. Custom made prosthesis we can do, but because at that time it was not available.
No, available or not available?
Yes, sir.
Any. This is the option?
Yes, sir. We can go for.
Better than the orthodesis?
no chance of
Yes, sir. Sorry, sir.
Next.
Next.
वो सवाल काफी है।
Dr. Aditya Kumar, junior resident, BMC Patna.
I just want to make one comment. In your slides, don't write full sentences, only write points. And then while you are speaking, convert them into sentences. Then the slide becomes 5-6 slides.
However, the excessive crowding of the slide should not be there.
Dr. Anupray Chaudhary?
Yes, sir.
Yes.
Good morning, respected faculties. For the topic of my paper presentation today is completion of platelet-rich plasma and local corticosteroid injection in adhesive capsulitis of shoulder, a prospective study. Adhesive capsulitis, also known as frozen shoulder, is characterized by progressive pain and stiffness of shoulder, usually resolved spontaneously, but in up to 40% individual it persists. Histological features include active fibroblastic and myofibroblastic proliferation in the rotator interval, anterior capsule and coracofemoral ligament, particularly associated with diabetes, hyperlipidemia and hypothyroidism. Treatment includes analgesic anti-inflammatory drugs, a steroid and PRP injection, and arthroscopic capsular release. My aim for this paper is to evaluate the outcomes of PRP injection versus corticosteroid injection in the patients with shoulder pain. A prospective study was carried out from April 2020 to October 2023 on 60 patients, which were divided in two groups of 30. Group A received 2 ml of autologous PRP and Group B received 2 ml of triamcinolone injection, 40 mg per milliliter. Patients were followed up monthly for 6 months using VAS course and USG of shoulder joint was done. Inclusion criteria was all patients were aged between 30 and 75 years with shoulder pain who failed NSAIDs and physical therapy regimen, and any patient with infective pathology of shoulder joint, non-compliance with therapy protocol, and patients having blood dysplasias were excluded from the study. How PRP injection is done? 10 cc of autologous blood is drawn. Using ACP system, blood spun for 5 minutes at 1500 rpm. Then platelet-rich plasma is collected. And the site of injection, we use posterior approach. The needle is inserted 2 to 3 cm inferior and medial to the acromion process and directed towards the coracoid process. An 18 gauge needle should sink completely into the joint and the plunger should push with great ease and no resistance should be there if you are in glenohumeral joint. Following were the results. After 6 months of the regular follow-up, the mean VAS scores in the PRP and triamcinolone group was 15.02 plus minus 3.25 and 38.65 plus minus 8.04 respectively, with a PS score of 0.0001 after 24 weeks, which showed significant improvement in both pain and disability in PRP group. The cortisone group showed better short-term outcomes, whereas PRP group showed better long-term outcomes in reducing pain and disabilities. Following are the USG evidences. Group photo A shows right shoulder USG with diffuse supraspinatus thickening and hypoechogenicity. B shows baseline supraspinatus tendon thickness of 6.7 mm. C shows USG guided injection at the right subacromial bursa, and D shows follow-up of supraspinatus tendon thickness after 24 weeks, 6.4 millimeter. So, what is the conclusion? Both corticosteroid and PRP injection can help relieve shoulder pain, but in long term, PRP is a better alternative in terms of better healing properties and safety profile, lesser side effects as compared to the corticosteroid injection, safe, cheap, and easily prepared outpatient procedure, potential to heal the muscle tendon unit of rotator cuff at the level of degenerative tissue. So, the take-home message is to choose the correct patient selection is the key to success. Role of physiotherapy is of great results in earlier stages. Correct site of injection is essential. Control of diabetes and other comorbidities are necessary, and the proper counseling of patients about the long-term benefits. Thank you.
Any complication during this process related to PRP?
Sir, no such complication I found. Just patient counseling was necessary to counsel them what we are going to do and what are the long-term benefits.
You have mentioned about 30 cases of PRP.
Yes.
Any chance of infection?
If we use sterile methods of injection, there are less chances of infection. Sir.
Have you given injection in diabetic patient?
Yes, sir. First we counsel them to have a physician consultation to.
Have you given injection?
Yes, sir.
How many patients?
Sir, 3 to 4
There are
percent.
no infection in diabetic patients after giving injection?
No, sir.
So when you repeatedly give you the steroid intraarticularly, what are the complications are there?
There could be an increase in blood sugar levels of the patient.
And how many patients you have given? Injection you have given?
In each patient, how many injections?
In each patient, how many injections you have given?
Mostly, sir, patients got relief after a single injection, but in a single patient, I remember 2 to 3 injections were given after a monthly interval.
Steroid 3 injections.
Yes, sir.
PRP 1 injection.
No, sir, only steroid group patient. PRP
Steroid 1
single.
injection and PRP 1 injection.
Yes. Sir, only 40.
एक इंजेक्शन दिया, एक ही पेशेंट को 3 इंजेक्शन दिया.
In corticosteroid group, sir, one patient needed 3 injections after monthly interval, but in PRP group, single injection.
You didn't mention the complication, I think.
Sorry, sir.
Okay.
Thank you.
Dr. Abhishek Pandey, 3rd year PMC Patna.
Good morning, everyone. I'm going to present a paper on constant and radiological outcome in patients with fractured head of radius treated with excision or replacement. Treatment options are conservative or surgical. Conservative options include above elbow slab, and surgical options are fragment excision, open reduction, internal fixation, excision or prosthetic replacement. In this study, we are comparing excision and prosthetic replacement. It is a comparative observational prospective study done in BMCH Patna on 16 patients from July 2022 to January 2024. The clinical outcomes are assessed on the basis of Mayo Elbow performance score. These are the inclusion and exclusion criteria to select the patients in our study. And mainly we use the Mason classification for the fracture of radial head. This is the Mayo Elbow performance score, which has a total of 100 points, having pain, range of motion, stability function, 45, 20, 10 and 25 points respectively. My first case is a 40-year-old gentleman who had a fall, presented late, about 2 months late to us, and we have done excision These are the pre-op X-ray and intra-op images of the same patient. And this is a 6-month follow-up of the same patient. The patient had excision and some restriction in pronation and supine is seen in this patient after 6 months follow-up. The second patient is a 33-year-old gentleman who had an history of RTA. Fractured head of radius is replaced with radial head prosthesis, and the clinical figure of this is an 6-month follow-up figure showing acceptable range of motion in flexion and extension. These are the results of 16 patients having the graphs of general distribution, age distribution. Duration of hospital stay was slightly more in prosthesis patient compared to excision. Time interval to return to work after surgery was earlier in excision patients. Complications were mainly seen in excision patients. Two developed instability, two had chronic pain after surgery, but none of the radial prosthesis patients had such complications. The pain score was seen at 1 month, 3 months, and 6 months. Obviously, the radial prosthesis patient had much tolerance to pain, have had less pain and higher pain scores, down to 45 compared to the excision patients. Range of motion at 1, 3, and 6 months was more in radial prosthesis patients. Stability was also more in radial prosthesis patients compared to the excision patients. And function out, the total score for function is 25. And obviously at 1, 3, and 6 months, the prosthesis patients have more function scores than excision patients. Total score was also more in prosthesis patient than patients. Concluding, considering early return to work, better stability, less complication, better ability to perform daily functions, radial prosthetic replacement would be a better surgical procedure when compared with that of radial excision, depending on the type of fracture and associated injuries. Thank you.
So, when you are doing your radial head replacement, how will you assess that the radial head is in the correct position? It can be go down, it can be very tight.
Yes.
How do you assess?
Sir, it's the main complication of doing a radial head prosthesis is overstuffing the radial head. We can assess by using the trochlea and the coronoid. It should be at the level of ulnar notch, not below it and not above it. 1 to 2 millimeter of this gap may produce significant functional results.
One more thing that you have put the implant, which is a straight one.
Yes, sir.
Do you know that the head of the radius makes an angle with the neck and shaft? The neck with the shaft?
Yes, sir.
How much the angle is?
Not exactly, I don't know exactly.
So how are you putting the straight rod when it is curved? It is an angle of 11 to 14 degrees. What is the purpose? How will you correct that?
So it's for rotation on the so that in projection and supination it correctly fits on the articular surface of radius.
Did you do the cemented one or uncemented?
Sir, mainly cemented, sir. One of them was uncemented, but I do not have his records. Most of them were cemented ones.
Answer is when you remake, you make a straight passage. That's it.
Suppose one patient came to you with severely comminuted fractured radial head in position. You will excise it or replace it.
So we will first assess the range of motion, his proportion of pain, and if the restriction is there, we may excise it, and we have to check the stability, sir, also. Excision is only accepted in severe third or fourth Mason grade fracture if the elbow is stable. So before excising, we assess the stability of elbow. If it is stable, excision would be enough. But in unstable, we have to go for the radial head replacement.
Patient don't want surgery, excision or replacement. Do you leave it as such?
Sir, it is recommended in severely comminuted fractures that we do not go for the conservative.
It is also recommended in such a case you leave it such for 3 weeks and start movement, patient will be all right. A patient, a doctor patient is still working after 25 years and his elbow is good, but after 25 years there is some osteoarthritic changes there. But 25 years really, he lives life as a normal. You can leave it or essentially you excise.
There is an option of delayed excision after 1 month.
Yes, either do excision within 24 hours or after 24 hours. 3 weeks.
Thank you, sir.
Dr. Aman Mohan, 3rd year PG PMCH.
Good morning, all faculties. My talk to present operative benefits of a scat about getting traumatic cerebral cervical spine injury. Cervical spine injury accounts 3 to 4% of all trauma cases. Cervical spine injury accounts 2/3 of cervical spine cases. It estimates 40% of these injuries will be unstable and potential for neurological injuries. Aim of the study. Methodology. The study takes place in departments of orthopedics, Patna Medical College. Prospective study is duration is 1 June 2022 to 31st December 2023. Age, inclusion criteria, age more than 18 years and less than 16 years, all cervical spine injury including fracture, subluxation, traumatic disc prolapse in more than one column involvement. Exclusion criteria is less than 18 years, more than 16 years, associated with other injuries, a patient with severe comorbid conditions. Anatomy of cervical spine, exclusively in cervical spine, foramen transversum present and spinous process is 5 feet. Initial management of all cervical spine patients or spinal cord injury patients, ABCD, we follow the adherence protocol of ABCD. Secondary survey to look for spinal examination and tenderness by dog drowning, clearing the cervical spine using Nexus criteria of Canadian cervical spine rule. Different classification we have used for classify the cervical spine injury, in which Allen Ferguson classification system, cervical spine injury severity score, cervical spine injury classification, and new AO cervical spine injury classification. Most common we use Allen Ferguson classification, which have 6 criteria categories: flexion compression, flexion distraction, vertical compression, extension distraction, and lateral flexion. In axial cervical spine injury score, we have 3 parts. We classify in 3 groups: morphology of fractures, disco-ligamentous complex, and neurological status. If the score less than 4 or less than 4, we manage conservatively. If 6 or more than 6, we go for a surgical operation, and if a score is 5, is decision taken by surgeon. White and Punjabi criteria for instability of force of axial cervical spine injury. Total 15 score given. If a score more than 4 or equal to, if a score more than 5 and equal to it, it's considered as unstable fracture. Operative indication for cervical spine injury: unstable injury, progressive neurological deterioration in patient with high incidence of late complications like kyphosis, more than 30 degree, loss of height of vertebral body, more than 50%, and some axial cervical spine injury score more than 6. This is standalone field. Crop images. Benefits of a standalone field: reduce the incision length, less operative time, decrease soft tissue handling, and cage has 0 profile, so it decreases the force of dysphagia more than during the anterior cervical Conclusion, decrease hospital stay, early mobilization, minimize the risk of bed sore and lung infection due to less time for bed-ridden patient, early start oral feeding because less chance of dysphagia. This is Indian Journal of Spine Surgery. Thank you, sir.
The indications of surgical indications of operation.
Surgical is a more than 2 column fracture in which medial column is always present or progressive neurological dysfunction. In MRI, obvious compression in a spinal cord and progress or paraplegia, vertebral body fractures.
If there is a complete quadriplegia,
Yes, sir.
we will do operation of.
Yes. So if MRI tells me compression is present, we go for operation.
Quadriplegia is important finding or not. In quadriplegic patients, we prefer operation.
If history of trauma is present, sir.
History of trauma के बाद ही quadriplegia.
Yes, sir, I go for.
Why?
Because sir, if I found that compression is present, then we remove the compression.
What is benefit of operation in quadriplegic patients?
Neuronal plasticity के वजह से
Not improve the neurological findings in quadriplegics. Nursing care will be improved. Early mobilization, walking will be improved. These are the findings in quadriplegic or paraplegic. You will not improve the neurological findings when there is a complete transfer. So you will do the surgery for different findings. Thank you.
Thank you, sir.
Dr. Anant Akas, IGNS. Dr. Anant Akas. Anant Akas, है कोई? Dr. Raviranjan Kumar.
Good morning everyone. Today my topic is a comparative study of post-operative outcome of clavicle mid-shaft fracture treated by nailing versus plating. Clavicle is a S-shaped bone, forms a part of shoulder girdle. Middle shaft clavicle fracture is most common fracture, accounting for 70-20% cases, which affects one's quality of life. Several treatment modalities are available, including conservative and operative methods. Non-union is common in middle shaft clavicle fracture due to medial fragment is pulled posterior-superiorly by sternocleidomastoid, and lateral fragment is pulled inframedially by pectoralis major and weight of the arm. In this study, we investigated the outcome of two standard surgical modalities of treatment of displaced mid-shaft clavicle fracture by TENS and plates. Objective of study: comparative analysis of outcomes of mid-shaft clavicle fracture in patients treated by plate osteosynthesis and medullary nailing. This was prospective study, and we have included 21 patients, 13 males and 8 females of middle shaft clavicle fracture. We have included displaced middle shaft clavicle fracture, open fracture of clavicle, and fracture with impending skin perforation. We have excluded the patients which are fractures associated with ipsilateral scapula and humerus fracture, old age debilitated patients, psychiatric patients, and patients with seizure disorder. We performed closed or open reduction and internal fixation in 21 patients. 12 patients were underwent plate osteosynthesis and 9 patients underwent TENS. The patients were followed up at regular interval 2 weeks, 6 weeks, 12 weeks, 24 weeks, and 48 weeks. The surgical outcome were assessed both from functional and radiological standpoints. The outcome was evaluated based on the constant Murray score. In plating group, 9 were functionally satisfied, 1 in malunion and 2 were wound infection. In tense group, 7 were functionally satisfied, 1 malunion and 1 in wound infection. Mean age of the patients were 33 years. There were 13 males and 8 females in our study. Average constant Murray score in tense group was 82, while plating group was 68. Results. Tense and plating groups had almost similar union rates. Union times. The functional assessment showed better outcomes in tense compared to the plating group. Incidence of malunion was similar in both groups, and infection was more in plating groups. There, tense group. Surgical intervention using both tense and plate fixation are suitable for managing clavicle mid-shaft fracture, as both have similar functional outcomes. However, considering early recovery with minimal surgical complications, tense can be a preferred treatment of choice for managing displaced mid-shaft clavicle fractures. These are the photographs. Thank you.
Have you used TENS in the lateral third fractures?
No, sir.
So indications of TENS and plating are mostly different. Plating is better probably for lateral third fractures of clavicle, and TENS is only suitable for the mid-shaft.
Yes, sir.
Both cohort of patients are different. What is the ideal indication of plating of clavicle? Is it required in all fractures of clavicle?
No, sir.
What is the ideal indication?
Absolute indication.
Middle shaft
Absolute indication.
neurovascular compromise है तो after
In any case, was there neurovascular compromise in any of your cases? Not seen. So what was the indication in your cases?
fracture with impending skin perforation,
That is one.
widely displaced clavicle fracture.
Is there something called this floating shoulder?
Yes, sir.
What is it?
Fracture of clavicle and subcutaneous with scapular fracture.
There is something called this suspensory shoulder ligament complex. So if it is broken at more than 2 sides, you need to fix it.
Yes, sir.
But we have floating shoulder put up in this wooden thread.
It was put up in exclusion
Yes, sir.
criteria.
Whereas
If you compare that, you can use that exclusion criteria, but it is a better indication of plating. Comparison purpose, you can make
Have you seen any major contraction during plating or medical?
no, sir.
What it would be?
Sir, 2 questions only. हमारे time we are late. 2 questions only.
Neurovascular compromise. Interest मेरे में
नहीं fast कर दे सर. जी सर.
Thank you, sir.
1 or 2 questions only sir.
Dr. Manish Kumar.
Only 1 to 2 questions.
अच्छा सर, good morning respected seniors and faculties. My topic for the presentation is giant head tumor of distal of radius, log excision and reconstruction using ipsilateral proximal fibular graft. Production GCT comprises of 45% of all primary bone tumors. Common sites are distal femur, proximal tibia, distal end of radius and sacral. Distal end of radius tumors are known for recurrence and malignancy. Generally occurs at 20 to 40 years of age group with cycle in location and dysentery. Aims and objective to achieve complete tumor removal and to obtain adequate function result of the wrist after an en bloc excision of the giant tumor and the reconstruction using ipsilateral proximal fibular graft. Materials and methods: 8 patients were selected from December 22 and were followed for a minimum of 3 months after surgery. All primary, histologically and radiologically proven cases were included. Recurrences were excluded from the study. Age group 18 to 55, mean age is 35 years, all females, and 3 patients of comprehensive age group and 5 patients of comprehensive age group.
Comparison grades, first is latent, second is active lesion, and third is aggressive lesion. Latent lesion, bone maintain normal contour, and active lesion is deformity and expansion of bone, aggressive, swelling of right margin. Clinical presentation, first the patient has pain which is already during activity, but later it became evident at rest. Pain is rarely severe unless a pathological fracture occurs. Here is an X-ray showing active and aggressive lesions. We also do X-ray in patient as 3% of the patient with ECT has METs, pulmonary METs. MRI is also done to detect soft tissue metastasis. Pathology, multinuclear giant cells in seed of mononuclear stromal cells, area of storiform spindle cell formations. ECT of distal and tumor removal, grade 1 extended curettage and bone cement, and grade 2 and 3 tumor removal and reconstruction using ipsilateral fibular graft. This is a grade 1 tumor, local recurrences. Almost within first 2 years, when simple curettage and bone grafting is done, 30-40% recurrence, and extended curettage is done, less than 10% of recurrence. Lung mets are 6 times higher in recurrence cases. This is the first case. Patient of a 35-year-old female came with the wrist pain. This is the immediate post-op X-ray and after 6 weeks and 6 months. This is X-ray of fibula after the graft is being taken out. This is case 2. We have a pre-op and chest X-ray of the patient, and after this is immediate post-op. And after 3 months, we have examined the patient for thoracic supination and palmar flexion and dorsiflexion. This is after 6 months. This is a case 3 of a 40-year-old female with swelling over the wrist. And this is the pre-op X-ray, and after immediate post-op we can see. And after 3 months follow-up. This is after 1 year. The results: mean follow-up 6 months, average time for union and fibular junction is 18 weeks. No graft-related issue and infections. 3 wrist subluxation found, no non-union and no recurrences, no peroneal nerve weakness is found. Advantage over arthrodesis, preserve wrist flexion and extension. Complication: infection, CPN, palsy, deformity and confusion.
What were the commonest complication in your series?
Sir, it was infection which was
Which grade of infection it was? What is the difference between giant cell of osteoclast of giant cell tumor and osteoclast of other tumors?
Osteoclast of giant cell tumor, you see the pathology, the histology of the nucleus of the mononuclear cell and the nucleus of the giant cell are similar, which differentiate it from the other tumor which has giant cell. The nucleus is not specific.
Dr. Mahesh Kumar Singh, GNB resident, Patna.
Good morning, respected teachers and my colleagues. I am presenting my paper on locking plate. Locking plate used as a definitive external fixator for treatment of open tibial fracture. As we all know, open tibial fractures are a surgical dilemma. These are complex injuries with multifactorial outcome and variable prognosis. These are prone to extensive soft tissue damage and subsequent detrimental complications such as infection and non-union, historically associated with a high rate of amputation, sepsis, or even death. The advancement of surgical instruments and techniques along with emergence of evidence-based guidance have resulted in a significant reduction in complication. The classification, for the classification we use Westerlo and Anderson classification. According to this, wound can be classified into three types. Type 1 is low energy and with minimal soft tissue damage and wound size will be less than 1 centimeter. Type 2 will be higher energy trauma and laceration of greater than 1 centimeter with minimal contamination. Type 3A will be with adequate soft tissue cover. Type 3B will be extensive soft tissue stripping and with massive contamination, and type 3C will be with vascular injury which require repair. 15 patients were selected. All the cases were treated at Anup Institute of Orthopedics and Rehabilitation, Patna. And with the inclusion criteria, Gastillo Anderson open tibial fracture type 2 and 3A, and exclusion criteria were fracture with significant bone loss type 1, 3B and 3C, and degloving injuries. Under all aseptic precautions, the fractures were provisionally reduced with traction and manipulation and temporarily stabilized using KY. And after that, we fixed them with external fixation with the locking compression plate. And POP backslab with dressing and proper management of wound and pin thread was done. After 6 days, slab was cut below knee and full range of motion started, along with isometric quadriceps exercises and non-weight bearing mobilization with the help of Boacon. Patients were discharged between 11th to 15th post of day. Follow-up at 6 weeks, 3 months and 6 months with X-ray was taken. Partial weight bearing started between 8 weeks, 12 weeks. This is the first case. 50-year-old male came to the emergency with 4-day-old Gastillo Anderson grade 2, left distal 1/3 tibia with fibular fracture. And this is the immediate post-op X-ray, and this is after 6 weeks. And this is 3 months and 6 months post-op X-ray. This is case 2, 35-year-old male came to emergency department with Gastillo Anderson grade 2, proximal 1/3 tibia fracture. This is after 6 weeks, and this is 3 months. And this is 6 months. This is case 3, 56-year-old male, Gastillo Anderson grade 3A, treated with the external fixation with locking compression plate, 6 weeks post-op and 3 months. Out of 15 patients, 8 patients showed sign of union, and 2 patients showed delayed union, 2 patients non-union, 1 patient showed malunion, and 2 patients lost follow-up. Every time of union, metaphyseal fracture 3 months, diaphyseal fracture 6 months. Every time of partial weight bearing were 2 months. There was no cases of deep infection. Intract infection was seen in 1 patient. Advantage: greater range of motion of knee and ankle joint. Easy to do skin graft or flap. Easy dressing of wound, cosmetically better. Earlier partial weight bearing and easier to manage. Summary: the locking plate usually definitely external fixator. Provide a satisfactory functional result. The patient experienced a comfortable clinical case, force, excellent knee and ankle joint motion, and acceptable rate of communication, and safe, effective, and versatile unilateral external.
You applied this treatment and allowed walking after how many days?
Walking after the partial weight bearing after 6 to 12 weeks.
In the first case, there were 2 screws in the distal fragment and 3 screws in that external fracture can bear weight.
So initially we put a back slab, for 6 weeks.
Weight bearing. Total 5 screws, 2 screws in the distal part, 3 screws in the dorsal part. That construct will bear weight. Do you suppose?
So after callus formation, we can put partial weight.
This is not the definitive treatment. External fixator is for management of the soft tissue. This is not the definitive. After all, we must know this is not the definitive. If you allow, a strong construct will be fed. And this construct will not allow to bear weight, even partial weight.
2 screw is also not sufficient for.
Okay?
Thank you.
Dr. Sumi PG, J. Jawaharlal Nehru Medical College, Bangalore.
Respected faculties and members, today I will be presenting on a case on the study of surgical management of floating knee injuries. The term floating is defined as a simultaneous ipsilateral fracture of the femur and tibia that disconnect the knee from the rest of the limb. It includes both intra-articular and extra-articular fractures. Generally, a result of high weight, trauma, or fall from height may be associated with several life-threatening injuries, such as head injuries, visceral injuries, and sometimes neurovascular injuries. Frequently, these fractures are compound, which delays further management. Despite a high complication rate, early skeletal stabilization and timely post-operative rehabilitation offers the best chance of a favorable outcome. This is the classification according to Fraser, type 1, which is extra-articular fracture of the femur shaft and difascial fractures of the femur and tibial shaft, and the type 2 is intra-articular, further divided into 2A, B, and C. This is the X-ray of the Metro cell method. This study was conducted in our department, General Babarpur, from December 2022 to December 2023. 15 patients with floating knee injuries who were admitted to the General during this period, and then the inclusion criteria were considered for study with minimum follow-up of 2 months and maximum of 6 months. All cases were managed surgically. The purpose of the study was to determine the outcome of patients and after surgical management of the floating knee and identify prognostic factors for this injury. Inclusion criteria: all cases with cross floating knee injuries, compound fractures, muscular inversion type 1 and 2, patients aged greater than 18 years. Exclusion criteria: all cases of floating knee with bone loss, patients of age less than 18 years, fractures with extension into the hip and ankle joints, compound fractures, muscular inversion type 3A, B, and C. Surgical management: for femur fixation, available options include K-nailing, interlocking nail, distal femoral locking plate, distal femoral nailing. For tibia, it includes proximal tibia locking plates, interlocking nails, distal tibia locking plates. Intramedullary interlocking nailing was done wherever possible. Anatomical reduction was achieved for intra-articular fractures and fixed with plates and screws. Patients were operated under spinal or general anesthesia. In our study, in all cases, femur was operated first, followed by tibial fixation. Case 1, we have a 20-year male patient, RTA, muscular inversion type 1, had distal femur shaft fracture and proximal tibial shaft fracture, Fraser type 2C. Patient managed with two-step procedure. First, roll plating in the femur, followed by proximal tibia locking plate by Pivot technique for proximal tibia evacuator. This is the pre-op X-ray of the patient and the post-op X-ray. This follow-up at range of motion at 3 weeks post-op. Case 2, with a 30-year-old patient, polytrauma head injury, transferred to our unit after discharging from surgery department. Fracture of the mid shaft of femur with distal water shaft of tibia, Fraser type 1. This is the pre-op X-ray of the patient and post-op. Complications. Early complications include pin site infection, compartment syndrome, infections, knee instability, arthrosis, fat embolism, peripheral vascular problem. Late complications included delayed union, non-union, infection, knee stiffness, contracture, shortening, knee osteoarthritis, and amputation. In conclusion, floating knee injury is an indicator of severe trauma. Damage to remote organs should be suspected and systemically treated. Internal fixation of fractures permits early mobilization of the knee joint with good functional outcome and should be done at the earliest. Early and aggressive wound debridement with early stabilization provide good functional outcome in treatment of floating knee injury and hence should be given priority in the management.
How many cases are compound fracture?
Yes, sir.
How many cases of floating knee were compound?
Sir, we have excluded the grade 3.
You have treated how many cases? How many cases you have treated?
7 to 8 cases.
7 to 8.
Yes.
Is there any compound fracture?
Yes, sir.
Compound fracture?
Yes, sir.
How many cases?
7 to 8 cases of
7 to 8, all are compound.
Yes, sir. Compounding of the femur shaft, sir.
Total how many cases were there in your series?
Sir, total altogether we did a study on 15 cases. 7 cases were compounding, sir. Which included, yes, sir, vascular inversion type 1 and 2 only, sir. We excluded type 3.
Wound healed properly, there is no infection?
Sir, most of the cases,
There is nothing like most of them. How many of cases would heal properly? How many cases?
yes, sir. So in 30 to 40% of the patient infection vaccine developed infections in trauma centers.
Dr. Gaurav. Dr. Gaurav.
Good morning, chairpersons and delegates present here. I'm Dr. Gaurav and I'll be presenting a collaborative care, case on collaborative care in the comprehensive management of extensive orthopedic trauma. Mrs. Murni Devi, a 42-year-old female, she was taken to a local practitioner following a traumatic incident, who after providing her with basic first aid referred her to an MCH. She was involved in a high-velocity motor vehicle collision and resulting in extensive orthopedic trauma. The collision led to significant force impacting her body, and the initial assessment revealed a scenario of polytrauma, and despite the trauma she remained conscious and oriented, and she came with a complaint of pain and swelling in right arm, right forearm, right knee, and sutured lacerated wounds in the right thigh. There were 3 lacerated wounds in her right thigh, of one about 8 centimeters long, the other was around 11 to 12 centimeters long, and the third was around 4 centimeters long. On radiographic examination, she had a right shaft humerus fracture along with right both bone forearm fractures. Along with this, she had a severely comminuted fracture of the right knee joint, and it was kind of a floating knee. These were the CT 3D images for her knee joint. So for the surgical intervention, we planned an immediate external fixation of the right knee. After a waiting period, we planned for plating for the right humerus, along with tense nailing of the both bone forearm, and the last step was for bicolumnar tibial plating and arthrodesis of the knee joint. That to be decided on a later stage. So in the emergency, she was managed with external fixation of the floating knee, where wound debridement was done, fracture reduction was done, and a knee spanning external fixator was applied, and regular dressing was done afterwards. These are the pre-op and the post-op X-rays of after the external fixator application. This is the post-op wound status. After significant waiting, the humerus fixation was done with 8-hole dynamic compression plate application. And in the same sitting, both bone forearms were treated with tense nailing. These are the post-op X-rays for her plating of the right humerus and both bone forearm tense nailing. While the patient was en route to rehabilitation for the upper limb, regular wound dressing for the knee joint was done. However, the culture report for her pus in the right knee joint came out to be positive for Pseudomonas, and it was sensitive to few drugs. So we started the patient on significant antibiotics. Now we have to make a decision whether plating was to be done or arthrodesis was to be done. Since this was a Fraser 2C type floating knee, there is a debate whether plating to be done or arthrodesis to be done. However, patient factors that influence the decision-making process were, patient was belonging to a very poor socio-economic background, and she refused staged procedure and costly implants. Longer physiotherapy with suspicion of stiffness favored arthrodesis. Severe contamination of the wound with Pseudomonas resistant to multiple antibiotics further supported the decision for arthrodesis because we couldn't place an inside implant. And severe soft tissue damage where definitive internal fixation was unsuitable. This approach was taken. So finally we went with knee arthrodesis and LRS placement. When we debrided the tissue, we removed all the subchondral bone and we placed a fibular strut graft along with autologous cancellous bone. And this was the immediate post-op after the knee arthrodesis was done. After 2 months, this is 1 year later, and she was provided with calipers for walking, and this is her walking 1.5 years later. Thank you, sir.
Ultimately,
Shut down. Yes, sir.
Okay.
Yes, sir. I have a video, sir, but since the time is up, I couldn't play that.
X-ray is not.
Yes, sir.
X-ray is not going to bend.
So she is walking with the help of after 1 year we started her walking with walker, but after 1 year she is walking using the knee ankle foot orthosis calipers. Thank you, sir.
Dr. Gaurav Kumar Singh, Eastern Medical College, Jodhpur, Rajasthan. नहीं
इस सेशन में कोई है तुम्हारा फ्रेंड है तो उसको बुला लो। नहीं आया तो आपसे स्टार्ट करेंगे। अमन ठीक है अरे अमन अपने क्या है अंशु बाद में नहीं पता कि हमारा मिस हो गया बीच में घुसने नहीं देगा नीलाक सचिन यस सर ग्रेट पीयूष गुलाब हो गया बोल रहे हैं टीचर बोल रहे हैं अमीन सायान सौम्यजीत कोई है रवि कुमार है अपना अपना डाल दियो सबको लोडेड है बताया कि नहीं किया पीजी सेशन में जो स्कोरिंग सिस्टम है फॉलो करने का कोशिश करो you all know the points on which we are marking बताया है कि we will be marking you on the appearance of the paper, the slides, the content matter. Thank you. Content, what you have got in it, your delivery, how you present your paper, the visual aid, how you use those to your mic distance. प्रेजेंटेशन में तुमको कुछ पॉइंट करना है तो तुम कर पाते हो कि नहीं कर पाते हो और डिस्कशन तो योर each paper is of almost in total 5 minutes finish it by 4 if you cross 4 the 10 marks of the discussion will go off so try to finish it by 4 minutes 3:50-52 would be a best thing. Don't finish it by 3. That is also not good. That is also not good. इसलिए करे तुमको जाना है अपनी बात रखनी है कोई इंट्रोडक्शन ये वो अगर मगर देखेगा तुम लोग को जरूरत नहीं है straight to the point. So this is the way which we planning. तुम्हारा loaded है? हरी सर सब ready? स्टार्ट करते हैं पहला कौन है अमन अमन एक के बाद दूसरा ब्लॉक लोड करते चले जाना हम अनाउंस नहीं करेंगे बता रहे हैं कि डिस्कशन का पॉइंट्स है अगर तुम लोग नहीं पूछोगे तो हम पूछेंगे सिर्फ बात है कि तुम लोग कुछ पूछो बिकॉज द होल सिस्टम इज नॉट टू तुमको पेपर पढ़ के तुमको पीजी का एलिजिबिलिटी यू शुड बी एबल टू डू रिसर्च वर्क ऑन इट ट्राई टू प्रेजेंट इट प्रॉपर्ली तो एंड यू हैव टू आस्क क्वेश्चंस सो क्वेश्चंस पूछो नहीं पूछोगे तो हम पूछेंगे तो फिर हम अपने ग्रेट अमर
Good morning, respected sir, seniors. My topic for paper presentation is clinical outcome of conservative management in patient with partial ACL tear. Anterior cruciate ligament is most important structure in knee stability. It is one of the two cruciate present in the knee. It is made up of two bundles, anteromedial and posterolateral. ACL is one of the most common ligamentous in young and athletically active individual which can occur following direct or indirect trauma to knee. ACL tears can be divided into mild sprain, partial tear, or complete tear. Partial tear represents 10 to 20% of total ACL tears. American Medical Association describes partial ACL tear as grade 2 injury. Clinically, in patients with partial ACL tear, partial anterior drawer test and latchment test, if positive, show laxity with a hard or bony stalk as compared to full thickness ACL tear having a soft stalk. Anterior drawer test, latchment test and fever shift test are most commonly used test for assessment of ACL integrity. Latchment test is more sensitive and fever shift test is a specific test for ACL rupture. After ACL injury has occurred, partial or complete, initial goal is to reduce the swelling with ice, compression bandage and evaluation. Definitive care includes physiotherapy or surgical repair depending on type of tear, which help in preserving knee range of motion and long-term knee function. As ACL tear presents a variety of reasons, there are differences in functional department of patient. Thus, management of ACL tear must be tailored according to the severity of injury and patient demographics. Also, surgery has its own risk and complications, and thus careful assessment of all the factors needs to be done before choosing the appropriate line of management. And my place of study is Department of Orthopedics, PMCH Patna, and its prospective observational. Inclusion criteria is MRI proven partial ACL tear with or without meniscal injury in 15 to 45 year age group, and hard endpoint on latchment test or anterior drawer test. Sample size is 20. Outcome measures will measure the outcome by lysome score and knee laxity. Knee laxitometer. Rehabilitation therapy. Patients were subjected to rehabilitation therapy using various open and closed chain exercises in 4 phases for 3 months, and we only proceed to next phase when the goal of the range of motion or strengthening has completed. In this phase, then we proceed to the next phase. And the result is according to age distribution, 85% of patients were 15 to 45 age group. And the sex distribution were 65% were males. And in distribution of side of injury, 55% was right-sided. And the associated injuries included, most common was with road traffic accident, it was 60%. And the result was that there was a decrease in the laxity in affected knee over a period of 12 weeks. And the percentage of patients not requiring surgery is 0, that means 100% were correct. Discussion. Total 20 patients were recruited in the present study with MRI proven partial ACL tear. The mean age of patients included was found to be 28.2 years. Among them, majority 85% were in the age group of 15 to 40 years. 13 patients were male, while 7 were females. 11 patients were having right knee injury, while 9 had left knee injury. RTA was the most common mode of injury, that was 60%. Latchment test with hard endpoint was taken to be positive for ACL tear 90%.
Any questions from the house about this? Go ahead. 1 मिनट के अंदर हम लोग को खत्म करना है, जल्दी पूछो.
Have you considered the level of activity of the patients when this in your conservative treatment process? Because it depends. In the case of an athletic patient, will it do a conservative treatment in case of partial tear?
No, we have not taken athletically present.
The level of activity of the individual you have not taken.
Yeah, I have taken. Yeah, in this sample size it was not there.
How did you decide your sample size? तुमने डिस्कशन में डिस्कशन कहाँ किया? You pointed out what your discussion with other studies. What was the result of physiotherapy in partial? और स्टडी से तुम्हारा क्या comparative result है? It is good, bad, same.
Means follow-up. My indication was that follow-up time was just 3 months. in that 3 months there was improvement in the laxity and the range of motion.
Good, thank you.
Next, Anshu.
Anshu?
Absent?
Absent, great.
Some card lying in the school. Milan.
Yes, sir.
Okay, great.
Good morning. My topic, evaluate the extensile lateral technique in comparison to the sinus tarsi method for treating intra-articular calcaneal fractures. The calcaneum is the most commonly injured tarsal bone, with 60-70% of fractures being intra-articular, most often resulting from axial loading of the bone. Displaced intra-articular calcaneal fractures cause substantial disability problems after treatment. The delicate nature of the soft tissue and envelope has made operative treatment challenging task. Extended lateral and sinus tarsi surgeries are used for displaced intra-articular calcaneal fractures. Aim and objective to compare the clinical and radiological outcomes between the two surgical approaches for sinus type 2 and type 3 fractures, to quantify and compare both the treatment modalities. A total of 40 cases underwent open reduction intensification for treatment of intra-articular calcaneal fractures in the Department of Orthopedics, KMCH, Katihar. Inclusion criteria includes patients over the age of 17 years with type 2, type 3 fractures, closed fracture treated with operative management by sinus tarsi or extensile lateral approach. Study exclusion criteria includes patients less than 17 years of age with fractures classified as type 4, type 1, sinus fracture, open fracture, or with extra-articular fracture. Physical examinations and radiological evaluations of patients are performed. Open reduction and intervention using a sinus tarsi extensile lateral approach was studied in 40 cases. Man between loop test and Pearson's chi-square test were used to determine the significance of prevalence of complication and clinical radiographical outcome. Here are some pictures of both the approaches. Result analysis. The table shows patient demographics, including Sanders classification, with respective number of patients having type 2 and type 3 fractures. The table shows clinical outcome in both the approaches, which were calculated on the basis of 3 scores: AOFS score, BS score, and FFI score, and improvements seen in both the groups, and no significant difference were observed between the groups. The table above shows radiographic outcome in both the groups, which were calculated on the basis of 5 radiological parameters: polar angle, G-shan angle, height, length, and width. And likewise, the clinical results, radiographical results were no different, and no significant difference were observed between the groups. The table below shows the rate of complications were high in extensile lateral group, like wound complications, shoulder injury, and subtalar stiffness. Discussion: the study found that treating DIACF with sinus tarsal approach had comparable success to extensile lateral approach, but the ELA had more complications, notably wound healing. The study faces limitation due to small sample size. We believe that the sinus tarsi approach has become an effective, reliable method to treat sinus type 2, type 3 fracture. The sinus tarsi approach has a lower rate of wound complications than that of extensile lateral approach. Here are my references. Thank you.
Good. Any questions from the house? Nobody? Okay. How did you randomize between the two groups? When did you choose to do with the extensile approach and when did you do the sinus tarsi? What was the criteria on which you dealt with this? What was the randomization method which you did? आपने उसको कैसे सोचा?
तो जिस अच्छा वाला उधर ले लीजिएगा, पूरा वाला उधर ले लीजिएगा, वो खराब हो जाएगा क्योंकि बाइस.
So this is a retrospective study.
उसमें कुछ ना कुछ होगा ना, क्यों चुना गया, क्या नहीं चुना गया, कुछ इसके बारे में. Just any 40 patient was chosen. Randomization to exclude bias is important. है ना? चलो कोई बात नहीं. Very good. और कोई सवाल? Thank you. That's it. Slide change करो. Back up. Restart the.
Good afternoon, sir. Today my topic of discussion is retrospective study of determined
outcome the operative treatment for cross type of unstable malleolar fracture. At first introduction, ankle fracture is the second most common lower limb fracture. It accounts for the 10% of the total lower limb fracture. The incidence of malleolar fracture increases this stage recently due to the road traffic accident. One of the causes ankle fracture is low energy tibial trauma, often associated with osteoporotic fracture. The low energy trauma is commonly seen in elderly women, while the road traffic accident is seen in young adults. Thus, it has a bimodal age of distribution. Isolated malleolar fracture is most common malleolar fracture. It accounts 1/3 of the total fracture. With the advent of CT scan, it is better understanding and better pre-operative planning and the better outcome of the ankle fracture. Aims and objective. The aims are the studying the various pattern of the clinical presentation, localizing the various fracture pattern by radiological and imaging technique, and to analyze the functional outcome. The material methods are the inclusion criteria in the patient with unstable ankle fracture joint, patient with disturbing the ankle motility, patient age group between 18 to 65 years, and who are fit for surgery. The exclusion criteria are the fracture in children, undisplaced fracture, patient who are unfit for surgery, and the patient who had satisfactory reduction was achieved by closed methods. It is the retrospective study including total 36 patients aged between 18 to 65 years. The study conducted between January 2019 to June 2022. The methods are open reduction, internal fixation technique, and the outcomes are measured with foot ankle ability measure score and short form survey 36 years, minimum 1 year follow-up. These are the classification of ankle fracture, Lodge-Hansen classification and Dennis-Weber classification. Lodge-Hansen classification is two parts. One is the part the foot with the time of injury, and the other is the direction of injury. It's a supinated external rotation, supination adduction injury, and similarly the pronated foot external rotation and abduction injury. And Dennis-Weber classification depends on the side of the above or below the side of the syndosmosis. Type is below the syndosmosis, type B at the level of, and type C is above the level of syndosmotic injury. The case 46-year-old male, history of fall of heavy object over his ankle. The diagnosis malleolar ankle fracture, and is the follow-up after 6 months. This is the pictures follow-up after 6 months. And the second case is 65-year-old male slip and fall at bathroom, malleolar ankle fracture. Is X-ray follow-up 6 months, and the follow-up after 6 months. And the third case is a 24-year-old male patient, right ankle trauma while playing kabaddi, diagnosis of bilateral ankle fracture. He speaks tibula is fixed with 1/3 tubular plate, and the medial malleus is fixed with the TBW. And this is a post-operative X-ray after 1 year. This is the clinical picture. And the results. In our study, the most common ankle fracture caused as the road traffic accident, accounting for 44%, and the most less is sports injury. The complications, 4 complications are present. One complication is deep and superficial infection, and the 2 is the stiffness of the ankle. This is the classification according to Lodge-Hansen classification. Most common classification injuries: supination, external rotation, followed by supination adduction, and the equal percentage of pronation, abduction, and pronation, external rotation injury. As for anatomical type, 44% bimalleolar and 55% trimalleolar type. This is the tabulated form of scoring, and the right one is the bar diagram. The blue one is the 6-month follow-up, and the orange one color showing after 1 year. As we see, as the duration of follow-up.
Questions? What was the aim of your study? Bimalleolar, trimalleolar fractures. Don't we normally operate? It is a very much a big term. What was the aim to study this? The trimalleolar fracture, dimalleolar fracture now.
Studies aim is the measure the functional outcome of ankle fracture with various methods of surgical techniques which we have.
What was their various methods?
TBW 1/3 tubular plate application.
उसका तुमने अलग-अलग क्लासिफाई करके देखा था? सिर्फ फिक्सेशन देखा?
Individually, sir, not compared to individual.
आखिरकार फिक्स तो सबको करना है ना. इम्पोर्टेंट हम पहले अब मिनट खत्म हो गया तुम्हारा. तुम यहाँ पर हमको अपना ज्ञान बताने नहीं आए. You have to show your research methodology. तुम इस बात को समझते हो कि नहीं हो कि रिसर्च कैसे किया जाता है. तुम्हारा ज्ञान पेपर पढ़ना वो ठीक है, ज्ञान हमको नहीं बताना. तुमने रिसर्च क्वेश्चन कैसे फॉर्म किया, कि ये मेरा रिसर्च क्वेश्चन है, हम इसमें कैसे काम करेंगे, मेरा ये रहेगा, पहले से ही मेरा स्टैटिकल एनालिसिस कंसेप्ट क्लियर होना चाहिए। एक बार स्टडी जब स्टार्ट हुआ तो हमको सिर्फ डाटा भरना होता है, अदरवाइज एवरीथिंग शुड बी प्रिपेयर्ड फ्रॉम बिफोर हैंड। उसके बाद खाली को डाटा भरना रहता है। तो वेबर क्लासिफिकेशन तुम्हारे ट्रीटमेंट को कैसे मैनेज में इफेक्ट करता है? यू आर टोल्ड वेरी विविडली अबाउट वेबर क्लासिफिकेशन, तुम्हारे मैनेजमेंट प्रोटोकॉल को कैसे चेंज करता है?
So at the time of operation, we decide whether the ankle stability is present, syndesmotic injury is present or not, then we have to put the syndesmotic exclusion. In my case, only 3 cases are
ठीक है, स्टडी था। अब तो तुम सिंडोस्कोटिक था, वहाँ स्टेबिलिटी था कि नहीं था, वो नोट में लिखा हुआ होगा ना। इट इज अ रेट्रोस्पेक्टिव। ओके, थैंक यू वेरी मच सचिन। नाउ पीयूष।
Good afternoon everyone. My topic for the presentation is functional and ultrasonographic analysis of hand and thumb in smartphone gamers. Smartphones have become an indispensable part of our life. The user's time of smartphones has increased significantly due to easy availability of various applications, including mobile games, as well as decrease in the cost of internet browsing, leading to boom in the mobile game industry. As per reports, 80% of the young scholars use smartphones for around 5 to 6 hours daily. The ligament, tendons, muscle, nerve, bone and joints undergo adaptation and constitutional changes due to continuous strain and overloading with the repetitive movement of the joint, which can produce repetitive strain injury or overuse syndrome. Smartphone gaming involves the repetitive extension and flexion movement of the wrist, which may result in narrowing as well as an increase in pressure in the carpal tunnel, leading to carpal tunnel syndrome. Hence, a prospective control study was performed to study the effect of frequent smartphone gaming on the following: flexor pollicis longus, extensor pollicis longus, extensor pollicis brevis, abductor pollicis longus, and the median, with the help of USG along with its nickel and functional output. It is a prospective study it was carried between July 2023 to December 23 on 120 undergraduate students in our college between the age group of 18 to 20 years. History of using smartphones for more than 5 hours per day for at least 3 years. Exclusion criteria was any recent history of injury less than 8 months to the upper extremity, any inflammation, degenerative or neuromuscular condition of the upper limb which may affect the activities of daily living. Out of 120, 16 participants did not meet the required criteria, hence they were excluded from our study. The following are the assessment methods which were used using visual analog scale, hand volumeter, Finkelstein test, grip strength using ProSmart digital hand dynamometer, pin test was used by JAMA digital pins meter in pounds, and grind test. And we have found that by USG, we have found that the thickening of the tendons bundle, non-homogeneity of the tendons bundle ecostructure, and a white halo around the tendons, taking into account both acute and degenerative changes. These are the cross-section area of median nerve, and the frequent gamers we have seen that there is an increase in the thickness of the median nerve. In the EPL also, we have seen that frequent gamers have increased the width of the tendon in all the cases. For clinical and functional assessment, we have seen the VASO score is increased in case of frequently using mobile games, and grip strength and pin strength was decreased in frequent gamers. And by using Finkelstein test and grip test, we can see there is increased positivity of frequent gamers. The width of the thickness of the all the nerves and ligament has been increased. In the discussion, in smartphone users due to constraint of phone design layout, the adaptation of the thumb and the hand posture has been seen due to limited use of thumb and prolonged flexion of wrist impaction of the base structure in the hand, such as FPL, EPL, EPV, and APL, and the middle nerve it can be seen. Now study Finkelstein test was positive in 37% of the frequent gamers. The tendon of the hand and the median nerve were significantly larger, thickened, and the cross-section area greater on the dominant side of the participant who used smartphones for the longer duration, especially while gaming. High VASO score in frequent gamers were observed, suggesting that they are more prone to experience pain in their thumb. We conclude that this study demonstrates the frequent smartphone gaming may affect the hand function, decrease in pin distance, and leading to pain in the thumb, and can really develop tendinopathy and CTS.
Any questions? अगला साल जब पढ़ो तो अपने दोस्तों को बता के लाओ कि क्वेश्चन पूछ लेना भाई को. This gives you a better ये. हमने भी दिल्ली में पढ़ा है. I had the best paper award. तो ये हम जानते हैं कि अगला बार से जब तुम लोग पढ़ो it is for your boldness. तो दो दोस्त को साथ लेके आओ. एक क्वेश्चन हर जब तक आप पूछे तब तक आ जाना चाहिए. तुमने बोला कि उसमें CTVS का इंसिडेंस ज्यादा है. ये CTS का इंसिडेंस ज्यादा है. उसका कोई रेफरेंस है क्या? तुमको कहाँ से ये स्टडी मिला? कार्पेट सिंड्रोम का इंसिडेंस गेमर्स में ज्यादा है. ये स्टेटमेंट था तुम्हारे पे बना है.
Increase propensity to develop CTS.
ये कैसे आप जानते हैं? ये आपके पास स्टेटमेंट कहाँ से आया? कोई रेफरेंस था नहीं था नहीं था? आप ये कैसे जानते हैं? कोई स्टडी है उसके बारे में आपको जानकारी दीजिए. कोई स्टडी करना चाहिए. ठीक है. और what do you after doing this what do you suggest? तुम्हारा डिस्कशन लोगों ने तो उसका सजेस्ट क्या? Only what are the reason you can think that tendon was thicker? What's the inflammation?
No, we have excluded the criteria. Inflammatory degeneration.
What was the reason you can conclude? हम तुमसे कोई सवाल नहीं. आखिरकार जब स्टडी किया तो उसका कुछ कंक्लूजन होना. खाली मोटा था क्यों? Why? आखिरकार इसका कोई रीजन तुमको डिडक्ट करना होगा अपने स्टडी में. इसका I think या और other people think about this. और कोई स्टडी से कंपेयर करके देखोगे कि फलाना कंक्लूडेड कि भाई इसका ये रीजन हो सकता है. हमको ये लगता है. तब अच्छा है बुरा है. So ultimately you are working with just finding नहीं होगा. चलो good.
Good morning, sir. My study of titanium elastic nerve for the treatment of pediatric femoral shaft fracture. Introduction. Femoral fracture are among the common injuries of the pediatric age group treated in orthopedic surgeon. This fracture typically occur in the early childhood when the weak organ bone is changing into a stronger lamellar bone during the adolescence when the children are subject to the high energy trauma for the motor vehicle accident of the from the sports. Femoral shaft fracture represent approximately 1.6% of all the bony injuries in the children. For the long-term children who suffer with the fracture of the femoral shaft were treated with the same method, traction and the casting. More and more people have begun to see the benefit and fixation of the quick mobilization in the last 20 years. Titanium elastic nerve are minimally invasive, minimally traumatizing, stable under the movement and pulsar load-bearing biological and child-friendly osteosynthesis. And an objective to assess the outcome of the titanium elastic nailing in the femoral shaft fracture in children. Sort of the method and material. So the study was conducted in the Department of Orthopedics, Katyar Medical College, Katyar. 10 established 30 children aged between the 5 to 16, 19 boys and 11 girls at the recent femoral diaphragm fracture. Approval was obtained from the ethical committee of the KMC Katyar. Inclusion criteria and exclusion criteria. Inclusion criteria under the children had close fracture of the diaphragm of the femur and patient were followed with 6 months each possible. Exclusion criteria metaphyseal fracture, open fracture, pathological fracture and fracture with head injury. Study for the patient with femoral shaft fracture immobilized using skin traction in the Thomas plane after the vital stabilization. Plane radiograph the AP and lateral view of the thigh becomes the hip and knee joint. Except the fracture communication geometry and dimension. Nails are determined the French formula in the stomach of the diameter. Result were evaluated outcome the French scoring system. Result gender distribution of the terms used 37% of girls and 63% of boys. Age distribution 53% for boys. Mode of the injury 43% of the RTA and the pattern of the fracture 53% of the transverse fracture and the less is the combinator. This is 7%. Time interval between the trauma and surgery less than 2 days is 10% and most of that is 5 to 7 days 63%. That is the chart of the cost of the minor complication and the main is the main complication during after the surgery in limb lengthening. Short of the limb lengthening less than 2 cm 1% and more than 2% limb shortening. Malalignment of the varus angulation, valgus angulation, anterior angulation, posterior angulation and rotational malalignment. Discussion. There was the eligible Girls, 19 boys were present in the study protocol. In the study were 171 males and 58 females. In the present study, average age being the 9 years. Plain their study is 49 children range from the 6 to 16 years. Age of the 10.2 years. The average duration of the surgery of study was 69 minutes. In the same criteria, the average duration of the surgery was 63 minutes. The average duration of the hospital stay in the present study 15 days. Average hospitalization at the time was 12 days. The study conducted the same. Conclusion. We conclude that titanium elastic nail technique is an ideal method for the treatment of the femoral diaphyseal fracture in the children at the age group between the 5 to 16. It is a simple, easy, rapid and effective method for the management of pediatric femoral fracture with reasonable time of the bone healing. Use of the pen definitive stabilizing femoral shaft fracture in the children is a reliable, minimally invasive, facial protective treatment method. Here is the bibliography. Thank you.
Questions from the house? पूछना है? पहला को पूछो.
What is the difference between tens and enders? Can we prefer enders in this fracture?
इसका पूछना सिंपल है कि भाई आपने टेंस चुना, क्यों चुना? आपका एज क्या था? टेंस ऐसे भी पहले से जाना हुआ ही है, तो आप उसका एंडर्स से क्या नहीं कर सकते हैं? एंडर्स के ऊपर प्रेफर क्यों किया?
Because in टेंस we were facial protective and minimally soft tissue injury कम होता है.
एंडर्स जानते हो क्या होता है? नहीं. एंडर्स में भी कोई चीज वही होता है, इसीलिए we all the processes of टेंस is relatively more flexible nail and clean criteria तुमने या क्या बोला? Clean formula क्या clean formula?
Clean from the diameter of the
नापने के लिए क्या है? कैसे नापते हो? तो स्टडी की है.
Between the cortex का length और 0.4 से मल्टीप्लाई करेंगे तो उसमें जो डायमीटर आएगा.
Between the distance between the
cortex,
two cortex.
Yes.
At isthmus.
Yes sir.
उसको 0.4 से हम लोग मल्टीप्लाई करेंगे तो वो
जितना आएगा उसका टेंस यूज होगा अपने का.
वो एक टेंस होगा.
नहीं 2 टेंस होगा सर.
दोनों मिला करके उसका एक डायमीटर
होगा. डायमीटर से उसका 80% कवर होना चाहिए.
गुड, वेरी गुड. Sam? Up close to the mic.
Dr. Sai Chakraborty, presenting my case, comparison of platelet-rich plasma and steroid injection in the treatment of the plantar fasciitis. Plantar fasciitis is a localized inflammation and degenerative of the plantar. Heel pain is the most common.
एक सेकंड रुक जाओ. प्लीज.
पीछे में बाहर निकल. It's the most common symptom, and the pain is usually localized in the medial cataract tubule. In the acute phase, the pain is usually sharp, and the first step of the day is mostly painful. And there are various non-surgical methods like NSAIDs, extracorporeal software therapy, stretching exercises, creams, silicone gel pen, and the soft solution application are there. Methods approval for this prospective clinical comparative study was granted by the local ethical committee, and total of 50 patients are included in the study. The study has been conducted in the Department of the Orthopedics, Generics in Bhagalpur. Patient who has been diagnosed with the plantar fasciitis monitored for at least minimum of 3 months, but doesn't show any benefit from the conservative treatment, were included in this study. Inclusion criteria has limited the conservative treatment for at least 3 months, but not showing any significant improvement, and the informed conscious taking availability of the duration of the entire study is there, like 6 months.
Exclusion criteria, there is traumatic ill pain less than 4 months, diabetic patient, cancer patient, compressive neuropathy, any traumatic ill pain, skin disorders, pregnancy and lactating mother, and hypersensitivity to NSAIDs. And the picture is showing the centrifugal portion. The first portion is platelet core plasma and PRP reduced plasma. The Buffy coat is the platelet and the RBC is sedimented at the bottom. A total of 50 patients included in the study. Patients are separated into the PRP and the steroid group. And in the PRP group, the total 30 cc peripheral blood taken from the antecubital region mixed with 3.2% sodium citrate. Samples were centrifuged at a rate of 1800 rpm for 8 minutes at the room temperature. 2 ml PRP with 1% lidocaine and other groups 2 ml 40 ml methylprednisolone along with 1 ml 2% lidocaine injected in the foot from the medial side to the point of maximum tenderness, medial capillary tubercle. The results are showing using the upper score, American Foot and Ankle score, and the visual analog scale. The results are significant. The PRP group, upper score at 6 week 85 and 6 months was 90. Her score is 2.4 and 1. In the steroid group, the American Foot and Ankle score was 75 at 6 week, 80 at the 6 months, and the her score is 4 and 2.6 at the 6 weeks. PRP group has significantly higher mean, upper score, and pass. P-value is less than 0.001. The discussion, the pathology of the plantar fasciitis includes the degenerative changes in the plantar fascia with fibroblastic proliferation and limited inflammation. PRP stimulates the proliferation of various cell types in the tissues and activate the repair cells in the blood circulation. More than 30 bioactive proteins are found in the alpha granules of the platelets. With the growth factors, PRP stimulates the local stem cells, activates the repair cells in the peripheral blood and the bone marrow. Excessive inflammation inhibits apoptosis and metalloproteinase activity. The use of steroids is also useful. It is reported to be useful in short terms. The complications include the plantar fascial tear, hypertrophy, abscess, and the osteomyelitis. And the prepared PRP can be activated by the bovine or the human thrombin or the calcium chloride. In this study, the calcium chloride is useful. In conclusion, the administration of the PRP in plantar fasciitis appears to be more effective than the steroid injection in terms of pain relief and the functional outcomes. Thank you.
Good. Questions from the house? You talked about conservative treatment didn't have significant improvement.
Yes.
What was the significant term? Can you classify it according to your criteria? Significant improvement का मतलब किस grading पर तुम significant कर रहे हो?
The patient is able to walk being free, and the patient doesn't have any complaint about functional.
So there is no objective scoring way which you have taken. Patient कहा कि अच्छा है तो मेरा अच्छा है. It's basically a visual VS type of thing.
Yes,
अच्छा है तो अच्छा है.
Clinically, I suggest the patient to walk in front of me, so there's no pain. And
First step is more painful. धीरे धीरे ठीक रहता है. Secondly, how did you randomize these 20 patient into two group? किसमें हमको ये डालना है, किसमें हमको ये डालना है? ये आपने कैसे randomize किया? Blinded, double blinded.
Most of the patients I have already have the exclusion criteria also, and for inclusion.
What you have included? How did you decide कि हम इसमें PRP डालेंगे, इसमें steroid डालेंगे? इसका कोई randomization का तरीका है या just मेरी मर्जी?
Like, sir, I have asked the patient who have given consent to taking the blood from the antecubital region, those who are included in the PRP.
Good. Thank you. चलो जिनका
अभी भाइयों का देखे हैं भाभी का हमें कीजिए चलता भाई तो आप लोग रिकॉर्ड कर दिया होगा एक रिकॉर्ड
काट के
कोई कर दिए थे ना रिकॉर्ड
हाँ चलो करवा दें
बस यहाँ कितना देर वाले अंत 5
on prospective study on functional outcome of surgical management of volar Boacon fracture with volar locking compression plates. Introduction. Distal and radius continue to be one of the most common skeletal complex injuries, multifactorial outcomes, and variable prognosis. Volar Boacon fractures are uncommon and unstable fractures. Goal of the treatment is to have a good anatomical reduction. Volar Boacon fractures are uncommon and unstable fractures. The goal of the treatment is to have a good anatomical reduction and achieve the stability and union, which will help in early mobilization and avoid the complication of the fracture associated with. Locking compression plates decrease the compressive forces exerted on the bone to achieve the stability and also prevents the impairment of the blood supply and the periosteal compression, which will favor in the fracture field. This is the AO classification of distal and radius fracture. So my prospective study included 20 patients which were admitted in our institute, and I have used 3 locking compression plates, different types, and modified, and this approach was taken. And post-operatively, I have taken X-rays and clinical, through X-rays and clinical reports. The inclusion criteria was adult over the 18 years of age was taken, those who gave the medical fit, and those who were fit for the surgery and gave them surgical consents. And exclusion criteria are these. Implantation. Under all aseptic precautions, through the modified volar Henry's approach, I gave the 5 to 7 centimeter incision with the radial border of the flexor carpi radial tendon, deepen the incision, and between the flexor pollicis longus and the radial artery. Pronator quadratus muscle was elevated through the L incision and debridement of the fracture site and fixed with the volar plating. And also placed the POP slab for 3 weeks. These were the conventional locking compression plates and the multi-locking compression plates which I have used. These are some pics attached showing the modified Henry's approach of the distal radius and the locking plate fixations. So my first case was 34-year-old male patient with volar Boacon fracture. These are the post-op X-rays attached at 1 month and 3 month interval. These are the range of motion evaluation, different pics with the dorsiflexion and rotation combination. Second case with 57-year-old male patient showing pre-operative and post-operative X-rays showing union and a good range of motion. So results was calculated through the scoring system of modified Coney and Green O'Brien functional score, in which I had 10 patients with excellent results, 6 with the good and 3 with the fair results and 1 with the poor results. Conclusion: locking compression plates provide successful results in volar Boacon fractures with effective anatomical reduction, allowing early joint motion, and also provides the biomechanical superiorities. To summarize, overall fixation with the volar Boacon fracture with locking compression plates will have a good satisfactory outcome for the patient and surgeon, and a good comfortable clinical course to the patient. Complications were minimal. With 5%, in one case I have seen extensor pollicis tendon irritation, and one case was having a post-operative stiffness because he was not compliant to the physiotherapy. Thank you.
Thank you. Any questions? Go ahead.
How did you check for the adequacy of reduction intraoperatively? Like, what are the parameters for that?
So adequate reduction, radiological for me, depressed fractures, displacement of more than 5 mm and shortening of 5 mm and angulation of more than 20 degrees will be something present with most post-operative stiffness, or OA changes will be more.
Intraoperative में तुम कैसे बात करो यार 5 mm and 20 degree? You are asking about intraoperative.
Intraoperative, how did you check, assess the reduction that what you have achieved is
good,
acceptable or not?
So,
कोई बात नहीं, discussion. ठीक है. It is well documented now कि volar Boacon में आप सर्जरी नहीं करते हैं. We don't do anything else. तो तुम्हारा स्कोरिंग तो पढ़ना ही पढ़ना है. It will be good. It will be better. तो एक तुम्हारा क्या है? The thing which is already proved, we proving it again. इन कुछ रिसर्च पेपर है, तुम कुछ डालना चाहिए, नई बात तुमको सुना, तब मजा आए. चलो गुड, वेरी गुड.
Thank you.
चल स्वामी जी नहीं है रवि
Good afternoon, sir. Good afternoon, everyone. I am Dr. Ravi Kumar Shatri from Dhananga Medical College, third year resident. My topic for discussion is ipsilateral femoral neck fracture with femoral shaft fracture. Femoral neck fracture is associated with up to 9% of ipsilateral femoral shaft fracture. Although there are improved diagnostic methods, but there is still delayed or missed fracture are there. Methodology. It was a retrospective study done in DMC and PR. A study participant where the patient who underwent surgery for ipsilateral femoral shaft fracture with femoral neck fracture. I have taken the size of Indian patient and all the patients included in my study were all the patients who were admitted and operated for femoral shaft fracture. 9 of the ipsilateral femoral neck and shaft fracture were correctly diagnosed before the operation. One patient was misdiagnosed, in which femoral neck fracture was found on radiograph after the operation of femoral shaft fracture. Femoral shaft fracture fixed with anterior interlocking nail in 1 cases and with compression plate in another 8 cases. Femoral neck fracture were fixed with cannulated screw in 9 of the cases. And femoral neck and shaft of one of the cases were in with proximal femoral vein. One of the patient having misdiagnosis of femoral neck fracture were temporarily treated operatively. Femoral neck fracture were fixed with cannulated screw after close reduction and removal of fracture obtained finally. Ipsilateral fracture of the femoral neck and shaft were rare, usually encountered in high energy trauma. It was reported that incidence of this injury ranged from 2.5 to 6% of all shaft fracture and has tendency to rise. These patients are relatively young, usually the beginning of high energy trauma. The incidence of this kind of injury is low, and the symptom of femoral neck fracture are sometimes covered by those of femoral shaft fracture. Although pediatric surgeon overlook the physical examination of an injured baby. Femoral neck and shaft fractures frequently sustain multi-system injuries. In most cases, the femoral neck fracture line is almost vertical and it is not displaced or minimally displaced, and thus it has a little to miss the diagnosis. As CT scan in high suspicious patients is helpful to reduce diagnosis, misdiagnosis. And the treatment protocol include antegrade femoral laning with cancerous screw, this anterior to the nail for fixation of the nail. We can use long femoral nail and other various combination plate are also used, including a hip screw with a long slide plate, hip screw with short slide plate for the neck, and separate plate for the shaft and cancerous screw for the femoral neck. Antegrade, retrograde intramedullary nail for shaft fixation with cancerous screw placed superiorly to the tip of the nail for the neck stabilization. Patient presenting with femoral shaft fracture, especially in the injury resulted from a high energy mechanism, should always be evaluated for associated femoral neck fracture. Appropriate preoperative, intraoperative, postoperative imaging of the femoral neck can be effectively used to rule out or identify a fracture of the femoral neck. Furthermore, consideration of advanced imaging modalities such as fine cut CT can improve diagnostic efficiency and reduce the rate of missed femoral neck fracture. In our study, we concluded that this type of injury were caused by high energy trauma. It was suggested that general examinations should be performed to avoid neglecting the life-threatening injuries. Ipsilateral femoral neck and shaft fracture is a stable one. It should be treated operatively by internal excision. Thank you, sir.
Thank you. Questions? What was then the conclusion? You just enumerated the treatment option. What was the study you did? Did you do a survey or you did a surgery? Study. Most of you got in conclusion 1, 2, 3, 4 are the various method of treatment. तुम्हारा स्टडी क्या था? इन्यूमरेट करना था या तुमको उसके बारे में जानना था?
Sir,
कोई
actually I was just here to discuss the
in case of mist or so it was not work. It was basically a survey what you have been doing it over the high energy trauma. हमारे पेशेंट में कितना को था इसका कोई डाटा नहीं था. हाई एनर्जी ट्रॉमा इज कॉमन. हाई एनर्जी ट्रॉमा हमारा इन 10 पेशेंट में किसको हाई मेथड ऑफ इंजरी के बारे में कोई डाटा वैसा डाटा नहीं था सर. हाई एनर्जी ट्रॉमा को कैसे करो? मेरे पे हो गया या हाई एनर्जी हुआ? सो कुछ तो most of the patients were the victim of road traffic. That's why I don't know that high energy trauma. So when do you suggest should we do CT scan in all the patient or do you have anything in mind where should we do a CT scan? In our study we concluded that in all the patients we have multi-system injury or road traffic like high energy trauma, we should do free of CT scan. Excellent. Good. Thank you very much. Thank you. We do come to the session. Thank you very much. You can we will move on to the next session after this. Next session Abhishek is here? No. No. Abhishek Anand is here? Yes, sir. Abhishek Anand, Junior Resident, AIMS Patna.
Good afternoon, everyone. I'm Dr. Abhishek Anand. Today I'll be presenting a study which was conducted at our institute from 2021, November of 2021, on the topic Association of Malnutrition and Other Geriatric Syndromes with Hip Fractures in elderly patients, an observational prospective study. The fractures which were included in our study were intertrochanteric fractures, third-trochanteric fracture, subtrochanteric fractures, and neck of femur fractures. The prevalence in the aging population of these fractures, according to a study, is 1.6 million. It was recorded in the year 2000 and it was predicted that it will rise to 6.3 million by the year 2050. According to a study in George Institute of Global Health, which was published in 2020, out of the total hip fractures which occur in the Indian population, 20% of these fractures in the age group will be 60 years or more, and this will account for 600,000 of the hip fracture per year. And according to the recent mortality rates that exist in India, 40% of these people will pass away within 1 year. The objectives of our study, the primary objective of our study was to estimate out of the total patients, hip fracture patients which were admitted in our institute, the proportion of the patients in which malnutrition exists. This was the primary objective of our study. The secondary objective were to assess pre-dementia or dementia-like conditions in the elderly patients with hip fractures, and to assess the baseline nutritional status of the patient's recovery in terms of activities of daily living. For this, we used an observational prospective study. The study site was AIMS Patna Orthopedics Ward. All the patients who presented to us at our OPD as well as our emergency department were admitted and were treated further. There was no any comparison group, and the outcomes were measured in terms of mid-upper arm circumference, mid-calf circumference, Barthel index for the activities of daily living, and mini-Cox scale for dementia. Sample size we included all the patients who were admitted from November 2021 to November 2022.
the inclusion criteria that we used for our study was all the patients who presented with a radiological diagnosis of intertrochanteric fracture, pertrochanteric fracture, subtrochanteric or leg of femur fractures who fall in the age of 60 years or above. And we used mid-upper arm circumference of both the sides, and to find the mean, we found the mean of both the sides, and we classified them as whether they had malnutrition or not. We took the cutoff to be 11.5 centimeter for mid-upper arm circumference. Mid-calf circumference, same way we found the mean of both the sides, and we considered less than 30 centimeters as an average for the cutoff. Barker index was used to find for the activities of daily living, and Mini-Cox scale was used for the dementia scoring. Patients were classified as malnourished or nourished based on mid-upper arm circumference and calf circumference. And based on the Barker index, they were classified as whether they are totally dependent, severely, moderately, or slightly dependent on their attendees. And based on the Mini-Cox scale, whether there was presence or absence of dementia in these patients. After 2022, the results that we obtained were according to mid-upper arm circumference of the total patients that presented to us with hip fractures, 93.5% of them had malnutrition. And according to the calf circumference, 46.7% of them had malnutrition. Dementia was found to be present in 71.7% of this population, and based on the activities of daily living, based on the Barker index, 4.3% of these patients had total dependency, 1.1% have moderate, 1.1% has slight, and 35.9% of these patients has moderate dependency on their spouse. Discussion disproportionately
No, 4 मिनट में बंद होना है.
Okay. Any questions? अच्छा वो इसके रूल लेके.
हाँ जी सर.
अच्छा. Next speaker. Okay, okay. You are presented well. Mr. Arjit Kesri. Sir Arjit Kesri. Yes. Junior resident AIMS Patna. Topic is prospective randomized controlled trial. Impact of social.
Good afternoon, judges. My topic is: does patellar denervation through circumferential electrocauterization reduce the post-operative anterior knee pain following TKA compared to patients without electrocauterization? It is one of the most common elective procedures performed worldwide. Excellent long-term outcomes of this procedure, and it's one of the most successful procedures in orthopedics. Despite of that, there are few shortcomings of this procedure, which may be classified as post-operative anterior knee pain. So that leads to dissatisfaction rate to almost around 19%. The anterior knee pain is caused due to friction between the posterior surface of the patella and the femoral component of the implant. Anterior knee pain can be caused post-operatively due to patellar maltracking, due to patella baja, patella alta. It can be due to functional causes or mechanical causes. To overcome this problem, patellar replacement was started, but this became a problem in Asian population because a minimum bony thickness of 12 to 15 mm is needed after resection of the patella. But in Asian population, the patella is inherently smaller, so it became a problem. To prevent the anterior knee pain, then circumferential electrocauterization was started in this total knee replacement, so that to denervate the branches which causes the anterior knee pain, namely lateral femoral cutaneous nerve, anterior cutaneous branch of femoral nerve, medial femoral cutaneous nerve, and cutaneous branches of the saphenous nerve. But studies have also proved that this can cause avascular necrosis and damage to the patella in long run. In AIMS Patna, we have been traditionally doing circumferential electrocoagulation in our patients till late January 2022. So we want to evaluate knee subset of patients without this procedure and compare it with our historical control. This is an intraoptic picture showing circumferential electrocoagulation around the patella. Primary objective is to see whether this procedure has any effect in the future for anterior knee pain, and secondary objectives are to see whether this procedure will help in the knee scores in functional outcome in terms of Oxford knee score, knee society score, and the knee ROM score. It is a cohort study. The outcome measures will be measured by Patellar score, knee society score, knee ROM score. These are the details of Patellar score. These are knee society score. So these are the results. In nutshell, it can be said that 84 patients were included in my study. 12 of them which lost to follow-up. Mean follow-up duration was 11 months. 72 patients were then taken after the loss to follow-up, in which 36 belonged to the no intervention group and 36 were the control group. It is very important to say that there were no differences between groups in terms of site, preoperative clinical assessment or pre or post-operative radiological assessment. No revisions or reoperations were performed. The findings suggest that there was no significant difference at any point during the follow-up period between the two groups. So it can be easily said that in a long follow-up up to 1 year, there was no significant difference in terms of anterior knee pain, knee society score or knee ROM score post-surgery in the both groups. In our study, all 72 patients were followed up till 12 months. This could clearly remove the practice of patellar denervation during total knee arthroplasty, since patellar denervation may lead to degenerative changes in the patella, including AVN. It also leads to decreased sensory feedback, potentially affecting proprioception and knee function. It can result in difficulty with activities that require precise joint control. Altered biomechanics and decreased muscle activation around the knee could also contribute a long-term functional limitation and reduce patient satisfaction post-patellar denervation. So, we discovered that 6 months following surgery, the clinical results resemble 1 year, which can be said that our study would be valid at a very long-term follow-up. Thank you.
Any question?
Thank you, sir.
Dr. Sachin Kumar, HMRI, prospective study to determine outcome of operative treatment for close type of unstable malleolar fracture. This is Sachin.
Sachin?
No, sir.
Sachin is not here, sir. Sachin is not here. So next?
Next is Tariq Amin. Tariq Amin, Junior Cadet. Benefits of brush score in neck of liver fracture. Brush score. Yes.
Oh, but that, you are comparative with the DFM versus plating. Yes. Distal femoral fracture.
Good morning, everyone. I'm Dr. Tariq Amin, second year resident, and topic for today is comparative study of the result of distal femoral fracture treated by internal fixation with locking compression plate and retrograde femoral nail. Outlines what we'll be covering is introduction, aims and objectives, results, result, discussion, conclusion. What is the aim of this study is to compare the result of distal femoral fracture treated by internal fixation with locking compression plate and retrograde femoral nail. Introduction, distal femoral fracture are defined as fracture up to 15 cm of the distal femoral articular surface. The two surgical techniques which are commonly used are plating, that is the locking compression plate, and retrograde femoral nail, which is also known as DFN. LCP offers anatomical fixation, but open reduction hampers the natural process of fracture healing and is associated with high rates of infection and non-healing. Retrograde intermedullary nail has a mechanical advantage of an intermedullary device, and the biological advantages of are minimal disruption of blood supply and also stimulation of blood supply aided by renin. Material and methods. In this study, 40 patients with supracondylar fracture of femur with or without intercondylar extension were studied. All cases were treated in Katia Medical College. The patients were divided into two groups. Group A is closed reduction internal fixation or open reduction internal fixation with retrograde intermedullary supracondylar nail. And Group B, patients were treated with open reduction internal fixation with locking compression plate. The duration of follow-up was 6 weeks. To 12 weeks. Inclusion criteria: all traumatic cases of fractures or distal femur medically fit for surgery. Age bracket was 15 to 85 years. Closed or Gastello-Anderson type 1 and type 2 open fracture patients were involved. Fractures with or without intercondylar extension. Exclusion criteria: patients treated with other than locking compression plate and retrograde nail, patient with neurovascular injuries, pathological fracture, and Gastello-Anderson type 3 open fracture. This is the Muller's classification. Pre-op and post-op X-rays of the nailing and plating are these. Result: 70% of the fractures of group A and 65% of the fractures of group B were closed. However, remaining 30% of the fractures of group A and 35% of group B were of open types. 75% of group A patients were closed reduction, remaining 25% underwent open reduction due to partial articular extension. 80% of group B patients underwent open reduction in order to fix the plate properly and due to complex nature of fracture. That is AO type B, Muller classification, which we saw earlier. Average radiological union time was 16.42 weeks in group A and of 20 patients. One patient went into deep infection after 2 months. Nail was removed and managed with antibiotic bead placement done. Finally, fracture went into delayed union. The average radiological union in group B was 17.7 weeks. There is a chart showing degree of knee flexion achieved after surgery, which shows group A more than 110 degrees of knee flexion in 11 patients, whereas in group B only 2 patients gave more than 110, and group B majorly had patients showing knee flexion degrees between 90 to 110. Lobetel has demonstrated that 93 degrees of knee flexion is required for normal sitting, 100 degrees for stair climbing, and 117 degrees for squatting. But the acceptable degree for all these activities is somewhere around 110 degrees. Needs stable. It showed excellent results in group A for 10 patients and group B 9 patients. Need classification basically involves points like pain, function, working ability, and joint movement, gross and radiological appearance. It shows that the group B had 10% of outcome as poor, whereas group A had only 5% as poor outcome, which was significant. Healing time in nailing and plating procedure.
So, anyway, you complete what is your, put it better, DFN or plating, union wise.
So union wise, sir, nailing showed a better and early union in my studies.
What is the general, you have an opinion internationally through papers and peer groups, comparisons?
So plating shows better faster union.
What is your operation is other than what the majority of people have out there?
So the earlier study, Gelman study also suggests that nailing shows better and early union as compared to plating.
That is a femur, sir. Distal femur.
Distal femur, sir.
Which one? Extra-articular.
I've included both, sir, articular and extra-articular.
So, in which one you have not
So
seen?
basically, I'm including the fractures which are 15 centimeter from the articular surface. That is distal femoral fractures.
Your cases,
Distal
cases
femoral fracture.
are supracanal fracture. You mentioned it to supracanal fracture. While the case, one case
one
was a articular, had an articular fracture in extension. आर्टिकुलर फ्रैक्चर था ना एक में वही एक्सटेंशन पर तुम्हारा मेंशन की होते हैं कुछ पता
नहीं सनी कुमार
Good afternoon, everyone. Myself Sunny Kumar, junior resident from KMCH. Standing for your my paper on topic assessment of meniscal and cruciate ligament injuries of knee joint using MRI and arthroscopy. The introduction: MRI has revolutionized the diagnosis and the management of intra-articular pathology and ligamentous injury, being non-invasive and a highly sensitive tool of investigation. Early and secondary soft tissues are often picked up by the MRI. Arthroscopy, being a highly sensitive and specific procedure, is both diagnostic and therapeutic, but it is invasive. ACL is commonly injured ligament in the knee and is usually associated with meniscal injuries. Aim and objective of my study is to correlate the MRI and arthroscopy in the evaluation of the knee injuries. The material and method: about 80 patients were included in this study. The inclusion criteria was all knee trauma patient of any age with ACL and meniscal injury. The exclusion criteria was the patient with associated fracture of the femoral condyle, plateau, and dislocation contraindication for MRI imaging and previous knee injury surgeries. The study protocol: the MRI was performed with a dedicated magnetic extremity coil of 1 Tesla strength. Operative findings were documented in the operation theatre, which included the anatomical structure involved with the presence or absence of the tear dislocation, the status of the articular cartilage, and additional details when available. Statistical analysis: the composite data was tabulated on Microsoft Excel spreadsheet and studied for correlation. Statistical analysis was done by using descriptive with interferential statistics using the chi-square test and predictive values. The Spearman correlation coefficient was calculated to correlate the finding of MRI with arthroscopy by using the statistical software SPSS. These are the results. Discussion: study was included on the 80 patient clinically suspected of as having some form of internal derangement of the knee. Maximum were young patient of the age group 21 to 30 years, and around 66 of which were the males, which outnumbered the females in all the age groups. In 80 patients, the ACL injury was the most common finding in about 72%, followed by the medial meniscus tear in about 42% and the lateral meniscal tear in about 36.25%. We calculated the fluid in the injured knees and it contributed to internal derangements. Further measured the lateral suprapatellar pouch or the gutter, which is more sensitive than the midline pouch and more dependable than the para-ACL compartment. Our study correlated MRI finding with arthroscopy in about 55 patients and estimated sensitivity, specificity, and PPV and NPV. In our study, false positive and negatives were rare. Conclusion: the diagnostic yield is increased with appropriate use of sequences and proper analysis of images in non-plane. Despite the fact that arthroscopy has altered the management of knee pathology, most orthopedicians admit the limitation of the procedure in the evaluation of extra-articular pathology. Its invasiveness, cost, and uncommon but possible complications associated with it. In this scenario, the accurate and careful clinical examination with adjunct MRI finding will help in arthroscopy, which will ultimately benefit the patient in need. Thank you.
Any question?
What you think that what is not proper in your slides? How you can progress your slides?
How you can, first, you have to, anywhere, you have to identify user shortcomings.
So they have pictures from the
and then you have to find out way to improve. So I think what is wrong, what was wrong, or not up to mark. Nothing like wrong, not up to mark.
The one thing they have not used photographs. other thing, it is too much in one slide. So who are in the back bench,
It should be taught just a few lines so that people can concentrate upon that.
6 into 6.
I can go through it, can read it. It's very important for making slides. So many literature, so many things, nobody is interested. And by the time he is going through it, it should be salient points only, number one. The pictorial things should be also there. One can understand it very easily and very quickly. Thank
अरे तुम बीच
Next speaker. क्या नाम हो?
विद्यानंद कुमार।
विद्यानंद कुमार।
विद्यानंद कुमार कौन?
Which medical? Anup Medical Institute. Good morning, all of you. I am presenting a case study to evaluate the functional outcome after surgical management of intercapsular neck or the femur fracture in young adult managed with hip bolt and straight fibular graft. Introduction: management of the fracture neck or the femur continue to be a challenge to the treating surgeon. In older patient, implant arthroplasty is well established as an acceptable treatment of this problem. However, in the younger patient, attempt to salvage the femoral head is warranted. Non-union and avascular necrosis of femoral head are the two major complications. It is expected from the treatment of the intercapsular neck or femur fracture in young adult to retain the femoral head and neck, fix the femoral neck fracture rigidity to allow early weight bearing to reduce the incidence of avian or non-union. Classification based on Powell classification, it is based on obliquity of the fracture line. It has 3 tabs: tab 1, tab 2, and tab 3. In tab 1, Powell's angle is less than 30. It has good prognosis. In tab 2, the angle between Powell's angle is 30 to 50 degrees, and tab 3, Powell's angle is more than 50. It has bad prognosis. On anatomical classification, intercapsular, extracapsular type. Materials and method. I studied on 15 patients selected from the Anup Institute of Orthopedic and Rehabilitation, Patna, period between August 22 to November 23. Inclusion criteria: face and descent fracture, age group 20 to 40 years, agreed on voluntary informed consent. Excluded criteria: pathological fracture, neglected fracture, medically unfit patient refusing for surgery. Implantation: these are hip bolt and cannulated screw with washer. After proper reduction and positioning of the patient on fracture table, proper painting and draping was done. Skin incision was given 5 to 7 cm. Then a central guidewire was placed on the AP and lateral view under CR guidance. Then culvert guidewire was placed parallel to the central guidewire. Then third guidewire was placed. After drilling the calcar guidewire, hip bolt was placed, and superiorly after drilling cancellous hip screw was placed parallel to the central guidewire. Then in central position, fibular straight graft was given. In case 1,
This is pre-op picture, then post-op picture, then 6 months follow-up. There is no sign of alien and there is a good union. In case 2, this is the pre-op picture, post-op picture, then 6 months follow-up. There is sign of union and no sign of non-union. Therefore, in conclusion, surgical management of intercostal neurosacral fracture with hip bolt, cancellous screw and tubular simple, adequate, inexpensive biological technique with better outcome if done as early as possible with good fracture reduction. Intercostal intercostal neck fracture as seen elderly patient after trivial trauma.
So, doctor, you saw 2 cases, okay?
Yes.
And then
we followed on 15%.
No, you followed up with it. What you came up with, showed us 2 cases, okay, that is not a problem issue.
Yes.
But there was no proper AP, it was an optic sort of no proper lateral. And only optic, or AP you can call it. In one, only lateral was there, so lateral, not absolute. What is the lateral, what are the lateral positions? You have any idea? What are the lateral positions? X-ray, lateral, what are the lateral X-ray? And the way it is taken, do you have any idea? And what is called that? No.
Lateral position of the CR.
CR or X-ray?
CR.
Everything remains the same. There are so many views for particularly 2 views for taking, 2 ways for taking lateral. What are those views? No idea. Anyway, what is the nowadays people say, and particularly in some elderly person, if you are fixing it, it should be in a particular fashion, arrangement. What is the arrangement?
Divergent.
Divergent. That people are saying that apart from that, any classically divergent, but what should be the configuration in a space?
Divergent and
suppose you are applying 3 screws.
Insert CHS inverted and diamond shape.
Hold on. You are applying 3 screws.
Yes.
Got it? Where will you put the first screw? What will be the position of all these screws?
First, in the calcar, hip bolt, then tubular stud track in the
I'm not asking about tubular.
3 screw का position.
3 screw position.
Inverted training पता है?
What is inverted training?
Means calcar screw, then first anterior, then posterior.
Where will be the anterior? Where will be the posterior?
On lateral view, sir. On lateral view, on the
bone में बताओ.
Bone में this is neck. Suppose this is neck. ये देख रहा है ना? ये cut section. Where will be the in lateral view? Where will be the anterior screw? Where will be the posterior screw? And where will be the center?
Calcar screw should be center. Then anterior should be superior anterior. Then
where from you got this idea? No, you're entirely off the mark. That is called inverted. That is
inverted
triangle. Triangle क्या होता है? Base उसका ऐसे ना triangle होता है. इसको पलट दो तो inverted.
Means first screw नीचे रहेगा, 2 screw ऊपर रहेगा.
Central screw should go touching the calcar.
Yes.
In the center of the neck, in the lateral, and the AP touching the calcar. Again, above the midline, midline anterior, touching the anterior cortex, and the same way posterior. That is the inverted. Next.
Next one.
Piyush Kumar.
Sir, mine is already done, it's actually repeated. Mine is the second one of this system. Second one is also fine.
Arjit Kesri. You have two paper.
No.
आपने प्रेजेंट कर लिया
Anyone?
और कितने लोग कोई प्रेजेंट है उनको करना है
बात नहीं है मेरा
2 बजे से
सेकंड नेक्स्ट सेशन भी जब
सेशन खत्म हो गया 5
इसमें जो लोग
पाँच आएंगे लोग तीन ही हमको तीन ही लाया
एक अभिषेक मैनेजमेंट करो अभिषेक आनंद पहला प्रेजेंटर दूसरा अरजीत केसरी तीसरा तारिक अमीन सनी और विद्यानंद
ये कर रहा था तो देखो ये पहले वाला हो चुका था
दोबारा 5 है
तीन तो कर सकते हैं जो हम देखें तो आपको अपना वो ज़्यादा नहीं है अभी सेशन न्यूज़ ओवर थैंक यू आप मनीष देखेगा अरे राजीव क्या करेगा तुम राजीव संभालो
इसके बाद
Dr. Saurabh. Yes, sir. Okay. Just hold on a minute.
Ravi.
You ready with the presentation? Okay. All the presenters, they have uploaded the presentation. Focus clear.
अरे क्या करना है वहाँ फोकस कोई बात सर लगा पेपर
Today I am going to present a rare case report of giant cell tumor, the first metatarsal of the right foot. As we all know, giant cell tumors are benign, aggressive tumors, accounting for approximately 5% of all primary bone tumors in adults. It has been described histologically as a benign neoplastic lesion consisting of 3 cell types mainly: the mononuclear histiocytic cells, multinucleated giant cells that resemble osteoclasts, and the neoplastic stromal cells that are the main proliferating cell population. Clinically, GCT presents as a benign but often aggressive lesion with a tendency towards local recurrence, with patients typically presenting between the ages 30 and 50 years. Tumors generally arise in the metaepiphyseal region of the long bones, predominantly in the distal femur and the proximal tibia, but they can occur in the entire skeleton involving the sacrum, vertebra, and the phalanges of the hand. In this case report, we have a 1-year-old female admitted to Department of Orthopedics at LMC Sasaram with a complaint of pain and swelling over the medial aspect of the right foot for the past 8 months, for which she took treatment elsewhere. She had no history of trauma and gave the information that swelling over the right foot increased in size over the past 8 months. She has no known comorbidities. Upon examination and investigations, a globular swelling of approximately 5 by 3 by 2 cm was noted over the dorsal aspect of the shaft of the first and second metatarsal of the right foot. No ulcerations, skin changes, discoloration or localized temperature present. However, tenderness was present upon this swelling. The contralateral foot was normal and asymptomatic. These are the pre-op clinical images of the patient. Moving forward, the routine blood investigations along with ESR CRP were found to be within normal limits. Radiological investigations were performed which revealed a lighting expansile multiloculated appearance of the lesion with thin shell surrounding bone in the metaepiphyseal region of the first metatarsal of right foot. For proper diagnosis, histopathological examination was also advised. This was the pre-op X-ray. And upon taking the histopathological examination, it was found to be a benign giant cell tumor of the first metatarsal of the right foot. Coming to intervention, upon confirmation of the diagnosis, the patient was planned for operation after routine hematological and pre-anesthetic checkup. The patient was planned for an in-total excision of the tumor followed by fibulectomy with its use as a fibular strut graft along with autologous cancellous iliac crest bone grafting and fixation with multiple KYS. In this, a dorsal approach was used to access the first metatarsal with an incision of approximately 8 to 10 centimeters. After this, the fascia was incised and atrial tendon retracted, followed by incision of the joint capsule. Deep dissection was performed after this to expose the first metatarsal, which was excised in total. Thereafter, harvesting of the bone grafts from iliac crest as well as fibula was done, which was used as a fibular strut graft with autologous cancellous bone grafts at its ends. After maintaining proper length, alignment and rotation, the final fixation was done with the help of multiple KYs at the tarsal-metatarsal joint and the metatarsophalangeal joint and a through and through from the distal phalanx to the tarsals. These are the intra-op images. This image depicts the excised tumor in totality. This is the immediate post-op X-ray which was found. The immediate post-op surgical site. In terms of follow-up, the serial X-rays were taken at 4 and 8 weeks. Patient was then upon that followed up for partial weight bearing. And this was the X-rays which were taken which showed gradual formation.
Any questions?
Thank you.
No. Maybe you have taken fluoroscopic graft along with autologous bone graft from the iliac. Why you already have gone through the booklets or some papers which added both, or you have your institution has started doing this, especially if fibular graft is sufficient, then why you are using autogenous bone graft from? You are taking bone graft from two places,
yes,
fibula and the
iliac crest.
Yes. What is the need of it? Why you have to think you must take the graft from two sides?
Sir, fibular strut graft, as compared to fibular strut graft, iliac crest bone graft is shown to be being an autologous cancellous bone graft, a better osteoinductive properties, so it for the proper bone growth at the ends. That is why we plan to have them in support along with the fibular strut graft as a whole. That is why it was planned to take both of them.
You have not going through any previous paper or chapters. What is the importance of that? No, you just started.
No, sir, not.
It is used. So, you thinking you are giving two more surgery. Yeah? You are putting two more surgery.
Yes.
Two more painful sites.
Yes, sir.
If it is added advantage, either through the literature, you have gone through the literature. If it is suggested, okay. If it is not, simple fibular graft is sufficient for at least in foot. There are so many area bones are there in it, just like your fibular grafts, just like your iliac crest.
Yes.
Iliac crest is giving some you are harvesting for that purpose. This is cancellous bone.
Yes.
At least the foot there are so many bones are there. More or less it is the same nature, same in nature.
Yes.
So why you are adding double star?
Yes.
So must if you are giving any other you are including in this, you go through the books, you go through the literatures. If it is added, it's okay. I read so many only fibulas.
The donor side mobility is increasing. Okay, you are creating two donor side mobilities. Secondly, how are you checking the outcome of the surgery?
So, first of all, main complaint of the patient was the pain and the swelling. So first we checked on that. There was because we removed the tissues and tumor in totality, the swelling subsided and the pain has happened. There is no pain. Then we come down to the movement in terms of the functional. At 4 weeks and 8 weeks, 4 weeks there was minimal callus, at 8 weeks light callus formation was there. So at 8 weeks, because the callus formation was there, we planned to remove KYS. At present the patient is in Bangalore. We had to talk to her 2 to 3 days back, so we couldn't obtain the most latest X-rays. So we talked to her, the KYS she has removed over there only, and she will be sending the photos thereafter. So we have called her for.
So what would be a modality of investigation to check the union?
Sir, at present, first of all, we go for an X-ray.
Radiological, okay.
Radiological. Thank you, sir.
And the next speaker is Akash Aman.
Good afternoon. This is Dr. Akash Aman, junior resident, third year, DMCH. I am going to present a case of temporary hemiepiphysiodesis for genuine. Genuine is an outward deviation of long axis of the leg with respect to the long axis of thigh with inward angulation of the knee. Causes of genuine are congenital cases, infective, idiopathic, neoplastic, and traumatic damage to lateral condyle or lateral fasces of femur or tibia. Bilateral cases, idiopathic is the most common reason, physiological, congenital, metabolic, inflammatory disease, and paralytic disorder. The reason of the genuine is asymmetrical growth of the fasces of the knee joint involves excessive growth on the medial side and retarded growth on the lateral side of either femur or the tibia. Measurement of the severity. For the measurement of the severity of the unilateral cases, manular distance is measured from central plumb line on the affected side. For bilateral cases, intramanular distance is measured when both knees approximated together. Flexion test is to observe deformity can be attributed to either by the femur or tibia. If the deformity disappears upon flexion, it suggests femoral involvement. If deformity persists during flexion, it suggests tibial involvement. In case where partial deformity persists, both tibia and femur are likely involved. Treatment modalities. Conservative indications are age 4 to 7 years and intermanular distance less than 10 centimeters. Surgical interventions indications are age more than 7 years, intermanular distance more than 10 centimeters. Type of surgeries: temporary hemiepiphysiodesis of distal femur on the medial side, closing wedge osteotomy on medial side, opening wedge osteotomy of distal femur on the lateral side. Present case: age of the patient and initiation of treatment is 10 years. Primary treatment given was vitamin D and calcium for 2 months. Patient was investigated thoroughly to rule out other cause of genuine as trauma, infection, rickets. In this case, the remaining period of bone growth was 5 years, considering average age skeletal maturity. Severity of deformity was assessed by measuring the intermanular distance and the preoperative X-ray of the both legs. The picture was there. Temporary bilateral hemiepiphysiodesis of distal femur was done on the medial side. The patient was followed up at an interval of 4 months with serial X-rays and intermanular distance for the assessment of the deformity correction. The staples were removed at the age of 14 years after deformity correction and skeletal maturity was achieved. There were no complications noted in this case. Probable complications are undercorrection, overcorrection, genuine recurvatum, pin site infection, and pin breakage. Conclusion: hemiepiphysiodesis can be a good modality for the treatment in case of genuine patient before the skeletal maturity is achieved. Thank you.
Okay, you are finished in time. So, Akash, why did you choose a state? Could there be any other method by which you could have corrected the deformity?
Before the skeletal maturity, if we go for the osteotomy, it will get reborn for the deformity. So we have to deal with the physis before the spherical maturity.
Okay. So you are thinking of one more surgical procedure instead of non-surgical. Do you have any non-surgical procedure to manage the deformity?
So they are medium series, the conservative for the they are medium series to correct the deformity, sir, in the conservative management, sir.
Anything else?
Bracing, sir.
Okay. So the decision regarding the surgery was from your side or from the parents' side?
So we consult the parents for the surgery.
For surgery.
Yes.
Did you think of going for a non-surgical procedure? Is applying the knee braces, the calipers, the corrective braces, over a period of time that can correct the deformity and manage the condition of the patient?
It can be done, sir. It can be done, sir. But if the deformity persists, sir, we have to go for the osteotomy, sir.
Okay, if it persists, but first you should give an option of a non-surgical procedure.
Yes.
And did you go for any biochemical analysis of the blood of the patient? Regarding this, was it a metabolic event, metabolic reason for this deformity?
So we haven't done that, sir.
What was the cause of deformity?
Sir, it can be a diuretic reason, sir, because the most common cause of bilateral genital is idiopathic only, sir.
Why not rickets?
So it can be, sir, rickets.
So did you check for it?
Yes, sir, we have checked for the rickets, sir, by the biochemical modalities, sir.
So what were the investigations you got?
Sir, they were the normal, within the normal ranges, sir.
What investigations?
Sir,
what parameters were in normal?
Calcium, alkaline phosphate.
Serum calcium, serum alkaline phosphate, anything else?
Vitamin D, sir.
Vitamin D. Did you go for serum PTH level? Should have gone. Okay.
It's a case of basically what we are dealing with is a metabolic bone disease. Either it is orthopedic or some sort of changes in your vitamin D. If you are thinking about vitamin D, you have to go for the renal profile, you have to go for the liver profile. So these are the methods you have to look for. Just not hurry to the surgery. Proper treatment should be given to the patient. This is our motto. So what all I can decide is you have to go for the proper investigations, talk to your seniors, talk to your students. Even though try for the if you are started something, I want to do some sort of epiphysiodesis, role of epiphysiodesis with other modality of treatment, and it can make comparative study. It is better to go for the comparative study. Not nice to go for the epiphysiodesis. That is such a good outcome you have to. Thank you.
Dr. Abhishek. Mr. Hogia. We have got Dr. Nishant. No, sir. You are talking on
different interactions. Good afternoon, everyone. I am presenting paper on topic different interventions in CTE. First, we will talk about materials and methods. My study design was prospective longitudinal study, and place of study was Daroga Medical College. Sample size was 28 CTB patients. Inclusion criteria, cases of idiopathic CTB, and exclusion criteria was cases of CTB. Treatment. We will first talk about goal. To achieve, we have to achieve three things: 90-grade food, flexibility, cosmetically acceptable, functional and pain-free food in shortest treatment time. Principles: soft tissue contracture, release or stretching to restore normal tarsal relationship. Once normal tarsal relationship attained, correction should be maintained till tarsal bones demolished stable articular surface. Now we will talk separately non-operative and operative treatment. First we will talk about non-operative treatment. Several regimes have been proposed, including cleaning, tapping and casting. There are two methods of
combination. First, Kite's method and Ponseti method. Kite's method. Correction of each component separately. Correction was done in following order: forefoot adduction, heel varus, then equinus. Kite's errors. Mainly it used calcaneal pivot joint as fulcrum that blocks adduction of calcaneus, thereby prevents eversion of calcaneus. Non-operative treatment, Ponseti technique. Two-phase, treatment and maintenance phase. Treatment phase, it begins as early as possible during first week of life. Only manipulation is carried out, but cast is not applied. Order of correction: cavus, adduction with varus, and equinus. Cavus is used as fulcrum, and while in kites it was calcaneal pivot fulcrum. Ponseti technique: correction of cavus deformity, corrected by forefoot supination related to hindfoot along with adduction of forefoot. Tends to exaggerate foot inversion. Ponseti technique, these are the pics. Now we will talk about percutaneous tenotomy. Foot heading, dorsiflexion and tendon is felt. Grade of 11 size inserts parallel to medial border of tendon at least 1 cm above insertion and calcaneum. Grade is pushed medial to tendon and rotated 90 degree underneath it. Tendon is cut from medial to lateral direction. Pop is felt and cast is applied in maximal dorsiflexion and 70 degree abduction for 3 to 4 weeks. This is the pic. Now we will talk about splint. It is known as tennis ball splint. Consists of shoes mounted to crossbar in position of 70 degree external rotation and 15 degree dorsiflexion. Distance between shoes is set at about 1 inch wider than the width of infant's shoulder. CTB shoes. It has some special features: straight inner border, outer shoe rise, and no heel. These are the complications of non-operative treatment: rocker bottom foot, bean-shaped foot, fractures, failure of correction. Now we will talk about surgical treatment indications. In case of neglected CTB, relapse CTB, recurrent CTB, resistant CTB. Choice of surgery: 1 to 4 years soft tissue release, 4 to 11 years soft tissue release with osteotomy performed according to deformities. After 11 years, triple arthrodesis and talectomy. These are some names: Dracos operation, Carolese incision, Cincinnati incision, and tendon transfer. There is one splat. Lateral part of tendon is split and inserted to the point. We can also do that external fixation, case fixation, and lateral fixation. And this is the conclusion.
You prefer this different intervention in CT. First of all, you must know why you people are presenting the paper. This is basic importance of this. Yes. Whatever is good. Why physicists are given this task to present the paper? What is the importance of it? Are you hearing my voice?
Yes, sir.
What is the basic purpose?
The basic purpose is just we should know what to select case and intra-op, op and post-op and follow-up. Just to comparative analysis and follow the study.
Basically, government is wanting to improve the research procedures in our country or our medical institution. So you must have a specific points. You are just delivering this CTV can be treated by this method, by this method, by this method. If you all know,
But sir, it's a long process now. We cannot. In 5 minutes,
you are not talking about your to give lecture on all each and everything. My question is your focus, your question. Research question is not focus. Your subject is you have chosen different modality. Have you decided this modality will be better than this? What does past this modality can be done, this can be done, this can be done. So this is not good.
What sir is saying that if you have selected 25 cases of CTV, what was your mode of treatment and what was your outcome? That should have been presented, not what is given in the textbooks. The textbook says different types of treatment is there. But what you as a PG student, what you are doing, and that you need to present in your talk. Okay. Okay, ठीक है. Do you have any idea about any scoring system?
Yes, sir. Pyramid scoring.
Okay.
Okay.
In the meantime, we are uploading the presentation, I think. Who is next speaker? Shumanshu.
Yes.
You are ready for the presentation?
Managed with femoral neck system. It is an ambidextrous study. Neck of femur fracture are usually managed by osteosynthesis or replacement, in which commonly implant used as annulated tensioner screw, sliding hip screws. FNS provides angular and rotational stability, and it also allows compression and control collapse. The aim of objective of my study to assess the functional outcome of femoral neck fracture treated with femoral neck system with minimum follow-up period of 12 months, and to investigate parameters such as non-union, complication like non-union implant failure, avascular necrosis. Material methods. It is an anti-spectacle study involved 26 patients with follow-up period of average 24 months, in which functional assessment were based on lower extremity functional scale, Harris hip score during the final follow-up. Inclusion criteria is displaced or non-displaced neck of femur fracture. The age is more than 18 years up to 70 years. Exclusion criteria is pre-existing hip dysfunction and any other fracture in ipsilateral limb. This is the implant in which this is the implant of femoral neck system in which bolt, plate and anti-rotation screw with insertion instrument has been seen. The result of my study in 26 patients with the mean age of 48 years with mean follow-up period of 24 months shows the average median time is 16 weeks with no avascular necrosis, and when patient have non-union undergo revision surgery. This is the age demographic images. On the basis of functional assessment score, lower extremity functional scale showed 66 with maximum function of lower extremity functional scale is 83%. Mean Harris hip score is 88 with the excellent result in 34%, in good 42%, fair is 90%, and poor result showed 3%. On the basis of Gardner's classification, type 1 showed 100% excellent result, type 2 shows 33% excellent, 34% good and 33% fair result. Type 3 shows 25% excellent, 83% good, 17 were fair result, and type 4 shows excellent result is 36%, 36% good, 80% fair, and 9% is poor scoring. This is the cases, the pre-op case, X-rays, images, this is the intra-op case, images, these are serial fluoroscopic images, and the post-op, immediate post-op X-rays, and it's 1 year follow-up period. The patient having full range of motion with no limping or pain. This is a case 2, pre-op and immediate post-op X-ray. This is a 9-month follow-up, and this is one year follow-up. Case 3, pre-op, post-op X-rays, and this is a follow-up of 2.5 years. This is a maximum follow-up we have with a no non-movement. The take-home message is fracture should achieve anatomical reduction. Young patient require timely surgery, anatomical reduction, and stable fixation for good result. Neck of femur fracture managed with FNS is showed good functional outcome and lower complication rate like non-union, avascular necrosis, revision surgery, or implant cut through. And limitation of the study include it is a short-term study and single oriented based study. Thank you.
How it is different from other method of fixing the fracture neck of femur?
Sir, in cannulated screw, there is a collapse. The more is collapsed and the screw is pulling out. In this FNS, there is a collapse lag because of the control collapse through the bolt and because of the bolt and the anti-rotation screw. The collapse has been a controlled way. This up to 20 mm we can control the collapse in femoral neck system. And in sliding hinge screw there is a rotation of the femoral neck, but in femoral neck system the rotation of the proximal neck of femur is can be restricted through the instrument.
Any questions from?
Any demerits of your FNS?
Yes, sir.
Any demerits of FNS?
Sir, first is very high cost, sir, and the second is this is a new system, sir, recently launched 4 years, and we have to evaluate like avascular necrosis. But my studies maximum is 2.5 years. Up to for AVN, sir, minimum 2-year follow-up has to be present. But in my studies, only one case is 2.5 years follow-up. Thank you, sir.
Any other presenters? What's your name?
Rakesh Kumar, you are presenting on, I think, the last question.
Last.
Fracture.
Good afternoon, sir. I am presenting the paper on both bone forearm fracture in pediatric age group managed by titanium elastic measuring system. Sir, forearm fracture is most common fracture in pediatric age group, and diaphyseal fracture of the forearm is third most common pediatric fracture. The most common mechanism is fallen out at stretched hand. Most of these fractures are treated conservatively. In some cases, because of the different fracture configuration and displacement of the fracture, use some other method of fixation. Close intermediate fixation is recommended technique, avoiding the physis is tense. Tense is minimally invasive technique of reduction and fixation. So advantages of small incision, faster bone healing, minimum complication, maximum range of motion, cosmetically better. Materials and methods. This prospective study was conducted on patient admitted in ortho RMCS Patna between December 2022 and December 2023. On 20% of diaphyseal fracture, in his 4 organ fracture and 16 are closed fracture. In 13 are boys and 7 are girls, from age ranging between 6 years to 14 years. Sir, in closing criteria, age from 6 years to 14 years, displaced fracture, open fracture with significant instability, fracture in older children, malleable unstable fracture pattern. Sir, technique under GA is supine position. First, identify the distal radius physis and fracture size. Make a 5 mm longitudinal incision on the lateral side of the diaphyseal metaphysis, proximate to the distal radius physis. Taking care to protect the radial sensory nerve. Drill a hole in the bone 5 to 10 mm proximal to the physis. First perpendicular and then oblique towards the elbow. Depending on the diameter of bone, choose a titanium of across 2 to 3 mm. Reduce the fracture manually and pass a nail into the proximal diaphysis. The ulna can be made antegrade or retrograde. The antegrade nailing mark the course of the ulnar nerve. Make a 5 mm longitudinal incision over the posterior olecranon and drill a small entry hole. Taking care to protect the ulnar nerve, pass the nail across the fracture site in antegrade fashion. Sir, an unrelated proximal lateral intercoatal dated along metaphyseal border distal to the olecranon corpophysis, piercing peripheral fiber of the anconeus. Alternatively, for retrograde nailing in ulna, place a small D hole just proximal to the distal ulnar physis. Pass the nail retrograde, taking care to protect the lateral cortex. Once the fracture is reduced and nail is in good position, cut the nail across 5 mm from the entry point, irrigation below the surface. Sir, pin is introduced first in this displaced bone. Sir, case 1, 10-year-old child coming emergency with forearm pain and swelling. On examination, tenderness present on the forearm and decreased supination pronation. Already developed both bone fracture seen. So try to reduce but is not reduced. Then we draw picture of TENS. Sir, case 2, both bone forearm fracture. Managed by TENS follow-up after 2 months of X-ray. Sir, post-op here, after internal fixation, above level slide is applied. A good antibiotic coverage done, leave it waited. Sir, in follow-up, the slide is removed after 4 to 6 weeks. Range of motion started, the nail are removed after 6 months and participated in the for 2 months. The result of analyzing radiological and functional outcome. Sir, in C complication, Malinian 4, 4 patients, foramen stiffness is 2%, cortisol is 1%, ambulation 3% is electric model. Sir, conclusion. Depending upon the rate reduction and functional evaluation, we have concluded that this is very good method of reduction and fixation of pediatric body program as alternative to conservative treatment. Thank you, Secretary.
What was the diameter of your elastic units?
Approximately 3 mm.
Both radius and hours.
Radius and diameter of 2.5.
And what precautions you have taken to spare the spices?
Just problem to distal phases. And if you introduce in a antigen variant, we in lateral side of ulna, we introduce some distal to the radial phases, problem, ulnar problem.
So your study period was for how many?
1 year.
1 year. So what was the results?
That's a 100% Indian, but in 4% going mal Indian, later they remodel and normal.
The age group you had chosen was between 6 to 14 years. Could you manage all these patients by the non-operative treatment?
Yes, sir, sir, maybe ambulation present or a stiffness present.
Is ambulation a problem for this pediatric age group patients?
Sir, ambulation, if age less than 10 years, then 15 days ambulation is maybe managed, and if age more than 10 years, 10 days ambulation is documented by conservative. Thank you.
Next speaker, please. How many more? Akurati? Anyone else? The last not uploaded presentation yet? You are speaking on? Your topic is?
My topic is KO-virus deformity in a closed, after as a sequel of post-compartment syndrome in a closed tibial fracture.
Okay.
This is a case report. My moderator is Dr. Ritesh Gunu, sir, Additional Professor of Ortho in IIM. This is a 3-year-old male who reported by the parents with complaints of inability to move right lower limb, pain and swelling, inconsolable cry, and there is another history of trauma on 3/12/2020 due to fall in a pit at about 15 feet height, and got buried under the mud for about 1.5 hours. And there is history of loss of consciousness for about 3 hours, and patient had no ENT and vomiting or any head-related injury. And he was primarily managed with high groin POP slap at elsewhere, and later he presented to us after a week on 10/12/2020. And In the meanwhile, he was admitted in the ICU and had undergone general care, where a skeletal survey was done, and no other fractures was found except he was diagnosed with closed femur and tibial fracture. And on inspection at IGMS, there is a presentation. Patient had multiple bulla over his right leg and dorsum of the foot, and on palpation there is abnormal mobility over right side and right leg and mid-third, and both just dorsalis pedis and posterior tibial artery were palpable, and the neurovascular structures was intact, and but there is no movement at toes and ankle. And we managed this patient initially with external fixator application both at right femur and tibia, along with fasciotomy done in right leg under GA on 11th, one day later, and intraoperatively we found that the muscles of the right leg were dull, leafy red and swollen and non-contractile. Post-op, patient was put on high flow and POP slab and limb was elevated. This is the post-op period, and where we did regular dressings, and gradually there is a cannulation formation, and we had to do secondary closure of fasciotomy was done, and on 23rd December, and sensation and movement and all distal pulses were present at the time of discharge. This is post-op X-ray, and later in the follow-up X-ray after 1 month and 2 months later, we can see good signs of bone union, and later external fixator removal was done, and only agony POP slab was applied, and patient reported there is loss of sensation over L4, L5, S1 diagrams of right limb, but it gradually improved, and we did an LCS also. There is another follow-up X-ray which after removal of POP slab there is good signs of union. And in NCF, he was diagnosed with triaxiatic neuropathy, which later improved. Later, patient was lost to follow-up, and he presented to us 2 years later with contracture of right foot, and along after which he was conservatively managed initially, and sciatic neuropathy, and there is gradual improvement of neurovascular status, and sensation was regained. And this is his presentation when of the foot. Equinus and pronated foot was there, cavus was there, varus was there. And on the local examination, we could see heels, hypertrophic surgical scars, wasting of thigh and right leg, and prominent talus as compared to and equinocavo-varus deformity of the foot. And is compensated, and we manage this patient with just fixation. And in conclusion, I would like to conclude that background of the patient, fathers is important. He is a uneducated farmer. He did not identify this problem as a significant because patient was lost to follow-up immediately after the slab removal, and patient gradually developed cataract.
Okay, I got a point. So, the case which you presented, what was your take-home message? What you wanted to convey?
It's education of both parents, and necessary of follow-up is important, and in compartment syndrome, this is the most common, is one of the complications that gradually arise in the deformities and all as a part of compartment syndrome.
So presently you have lost the patient on follow-up. The patient is not in follow-up at present?
No, the patient later, now he was treated with just fixator, and we are gradually following up the patient.
Okay. Yes. प्रीवियस सेशन के स्पीकर सब लोग हैं कि सब चले गए? इधर वाले तो चले गए। ठीक है। नेक्स्ट सेशन
Good afternoon everyone, respected judges and chairpersons. Today I am presenting my topic on research for representing different types of pediatric clubfoot deformities after 1 year of age in Indian scenario. Clubfoot remains the commonest congenital cause of locomotor disability. These deformities, when present early, can be managed effectively with available treatment options. When left untreated, it results in a more complex deformity which is more difficult to treat. Most of the orthopedic research on the clubfoot today is focused on the management of fresh cases and the intervention. Late presentation of clubfoot is unusual in Western world due to early identification and treatment. In developing countries, large number of patients still present late with clubfoot. Aim of my study is to identify the causes for the late presentation of CTEV in more than 1 year of age. The primary objective is to enumerate the causes for the late presentation of CTEV, and secondary objective is to analyze the different types of late presenting clubfoot deformities. This is a observational cross-sectional study, and the inclusion criteria is the idiopathic CTEV, untreated, recurrent, inadequately treated in age more than 1 year, presenting to AIIMS Patna OPD. The exclusion criteria is the non-idiopathic CTEV, teratologic, neurogenic, syndromic, and the resistant type of CTEV. This is the proforma of the patients which came to the OPD. In this proforma, we asked, apart from the developmental milestone, when was the first consultation for the deformity was taken after the birth, and what was advised, and whom it was advised, and what was the correct treatment taken, and if the Ponseti treatment was advised, how many number of casts, and was the tenotomy was done or not, and we calculated the Ponseti score. These are some of the clinical pictures of the patient presenting late with the idiopathic clubfoot deformities after 1 year of age. Coming to the results, around 37% came in the age group of 2 to 5 years of age, and most of them were male, around 80%, and around 70% lives in the rural area. Most common type observed in this study was recurrent, around 40%, and 50% were bilateral. Around 25% of the mother were uneducated, and 30% of the fathers had education till primary level. Around 50% of the patients considered the orthopedician as the first consultant, and around 72% were advised on the serial Ponseti casting. Coming to the causes for the late presentation, socio-economic constraint remains the commonest cause for the family-related, and it is seen in the 72% of cases. Next common cause is the non-compliance for the basis and exercises. The doctor-related lack of skill to treat is the commonest cause, around 12% of cases, and the social factor lack of treatment facility in the rural area is seen in the 55% of cases. And 15% of the parent consulted required as the first consultant. This is the graph showing the family-related causes, and this is the doctor-related social factor and the paramedical and the which the parents consulted as the treatment option. Majority of the mothers were uneducated and fathers had education till primary level. 31 families had low income according to the modified BG Prasad scale. 25 children sought medical attention after 1 month of age. Most common cause of the delayed treatment was the socio-economic constraint, and mean total Ponseti score of 60 feet examined was 3.75 plus minus 1.33, and it was significantly higher in the untreated cases. Most common type of CTEV observed in this study was recurrent due to the non-compliance for the basis and exercises. Overall data suggests that there is a need for the more awareness and education in the society and to avoid stigma for the timely and appropriate management of the clubfoot. Crucial for the healthcare professional to diagnose and initiate treatment as early as possible to achieve optimal outcome. Thank you, Rajgir and Boacon, for allowing me to present my.
Vision is basically what we have derived. It is a uneducation. Our society is uneducated.
Yes,
the most common reason
is the social economic constraint. The poverty is the most common reason. As the club food is present since birth, but most of the cases are presenting after the 1 year of age. The study includes the patients presenting late after 1 year of age.
due to education or due to his
so there are multiple factors. Most common cause we found is the socio-economic constraint. The second one is the non-compliance for the basis and exercise. That's the most common type of observed by recurrent. They consulted, the deformity was corrected, but the deformity was recurred.
I want to catch this point. It's important. Still, there are so many medical colleges working with in our government orthopedic surgeons there. Free treatment, totally free. The plaster cast technique is needed for this treatment. So perhaps financial constraint is not so important if this number is so high. It is basically due to uneducation. Uneducated people, they are thinking, अरे ये तो ऊपर वाले का देन है. Education level is poor. जैसे वो ये ऊपर वाले ने दिया है तो वो ठीक थोड़ी हो सकता है. तो ये जो stigma है, this is stigma. This is very important. So education is very important because so many hospitals master technique is so costly. So awareness among this thing is very important, I think so. What do you think?
Yes, sir. So most of the children and parents lives in the rural area.
You have already talked to them. Why they are coming late? Basically, you have already tried this comes from socio-economic growth and so. No, what is the basic reason?
So if you education is also
what sir is trying to say is what was the basic cause of neglected club food. Okay, in your chart what you're showing us that is the socio-economic constraints.
Among the family reason is the most common.
And what was the incidence or the prevalence due to lack of awareness?
Sir, it's seen in around 11 patients out of 40 in 27.5% of the cases.
Because what again sir was saying that the socio-economic constraints, that's not much of significance at present, because we have got almost all the government institutes who are managing these cases free of cost. So socio-economic constraints should not come into that much of reason behind.
So the travel costs, they didn't come to the city to.
See, even the hospitals in the periphery, different districts have got government products, and there also it is being managed without any cost. Okay, so that can be there. Okay, anyway, no problem. Next.
Good afternoon, everyone. My name is Ahmad Jafar. I am a postgraduate resident at NMC Patna. I will be presenting on limb reconstruction system management of compound diaphyseal fractures as a primary definitive. High velocity trauma leading to open fractures are on rise in today's motorized society. Due to subcutaneous position of tibia, fractures of tibia more commonly results in an open fracture than any other trauma. A usual sequential protocol of treating compound fractures are initial debridement, external fixation followed by intramedullary interlocking nail with ream. The disadvantages of this technique are high rates of infection, need of several operative procedures, long period of hospitalization leading to increased economic burden to the already poor patients. External fixator is often the initial method of skeletal stabilization in these open tibial diaphyseal fracture, as it provides stable fixation, preserves vascularity of bone and soft tissue, leaves wound accessible and reduces the amount of blood loss. The conventional AO fixator can now be replaced with limb reconstruction system. Due to its anterior placement of tibia, LRS is more accessible to the patient for pin track care. It may be a better option in terms of initiation of early weight bearing and more rigid fixation. LRS has also been proven effective in treatment in the commonest complication following compound injuries in tibia, non-linear deformity correction, reconstructive procedure for gap non-linear using bone transplant, and limb length. LRS consists of assembly of clamps which can slide on a rigid rail and can be connected by compression distraction unit to achieve bone transplant. Hence, to avoid application of multiple fixator in same patient, LRS may prove as a single tool to deal with primary definitive treatment to manage wound and bony discontinuity. Aims and objective: union with attainment of limb length, early ambulation, invasiveness of the procedure, patient compliance, wound management, length of hospital stay, rate of complication like infection, deformity, post-operative results. Materials and method: the present study was undertaken at NMCH, Nalanda Medical College from 2022 to 2023. It includes patients with compound tibial diaphyseal fracture admitted through both the emergency and outdoor. Sample size was 12. Inclusion criteria included compound tibial diaphyseal fractures, Anderson grading type 1, 2, 3A and 3B compound diaphyseal fracture in the age group of 20 to 50 years. Segmental fractures of tibia compound, patient willing to give written consent. This was the Anderson classification. The instruments needed were rails, clamps, tapered thread pins, drill bits, dummy clamps used as template, compression distraction units, and aluminum. The patient was placed in a supine position with pump placed under the ipsilateral hip, CM placed on the contralateral side, proper scrubbing was done with betadine and betadine solution. Affected extremity was properly drilled. The proximal tapered threaded pin of the LRS was inserted longitudinal incision separating soft tissue. The first pin was placed 15 mm from the knee joint at the level of fibular head to avoid penetration of the joint capsule and pes tendon and the patellar tendon. Then the distalmost tapered pin was inserted in the same manner, 1 cm above and parallel to the ankle joint. Rotational alignment is checked before insertion of the distalmost pin. Rod assembly was connected after the proximal and distal pins were placed after checking rotational and stability and all. All tapered pins were inserted under CN guidance and distal cortex was not penetrated 2 mm beyond. In post-operative care, patient was put on antibiotics and we performed a repeated debridement 48 hours later, and patient were taught cordyceps and hamstring exercises. These are the cases. In observation, most patients were male in the age group of 31 to 40 years. Most had type 3A Gustilo-Anderson fractures. Most patients were able to bear weight within 12 weeks, and average union time was around 20 to 24 weeks. The most common complication was pin loosening.
LRS का प्रिंसिपल क्या है? बेसिक प्रिंसिपल क्या है?
So, external fixator, external fixation in the compound fractures.
क्या प्रिंसिपल क्या है? प्रिंसिपल बेसिक प्रिंसिपल की बात है.
So, compression distraction institution.
इसमें क्या?
So, इसमें तो compression, we perform compression. Stabilize the bone and in the form we provided a definitive fixation to the bone when there was not enough soft tissue coverage for permanent permanent.
मान लीजिए तुम्हारे पास 3B का है, क्या करो? 3B
Sir, periosteal disturbing bone is
3B. 3B का समझ रहे? क्या?
Sir, open fracture, open compound fracture of more than 10 cm with periosteal stripping.
So when we classify these open injuries based upon the Gustilo-Anderson method, when do you or how do you classify them? So when the patient comes to you in the emergency, look at the patient, look at the wound, do you classify at that time or do you do something before you classify them?
Sir, vascular, we do not know the vascular status after looking at the...
का मतलब जीरो पैसेंजर तो उसमें इन्वॉल्वमेंट होगा ना 3B में 3C में
repairable vascular damage 3C.
So is the classification given by Western Anderson, that classification is a pre-debridement classification or a post-debridement classification?
So it is a pre-debridement.
Take it down.
Good morning, everyone. I am Dr. Shubham Kumar, third year postgraduate student, BMC in Patna. I am going to present a paper on comparative study of the role of pronated quadratus repair versus no pronated quadratus repair in volar plate fixation of distal radius fracture. Several treatment methods have been advocated over the years for distal radius fractures. Recently, volar plating have increased in popularity out of those due to its low profile design, articular fragment stability, relatively low risk of flexure tendon ruptures, as well as early return to motion and functional strength. During volar plating, through standard hand-reach approach, pronated quadratus is typically elevated off the radial attachment to reach the fracture site, facilitate plate fixation. Now the controversy surrounds the merits of its subsequent repair. The objective of my study was to evaluate the functional outcome post-operatively between both the groups with respect to range of motion, post-operative pain, grip strength, post-operative complications, and test score. It was a prospective comparative study that was done in BMC Patna between May 2022 to January 2024, in which 4 patients were selected as per our inclusion and exclusion criteria. They were divided into 2 groups, in which pronated quadratus repair was performed in the study group A, and it was just placed in anatomical position, and no repair was done in group B, the control group. The surgical steps. Post-operatively, they were given back slap for 1 to 2 weeks, and weightlifting was not permitted until 6 weeks, till radiographic signs of union would appear. They were followed up with regular intervals of 2 weeks, 6 weeks, 3 months, and then 6 months. The outcomes were assessed for range of motion. It was done using a goniometer, visual analog scale for post-operative pain. Grip strength was measured with a dynamometer, and DAS score through questionnaires. We can see the basic demographic information in the table. For this range of motion, we can see at the 6th week there is slightly higher flexion and pronation range of motion in the group A. Otherwise, no significant difference could be appreciated throughout the follow-up in both the groups. In case 1 and case 2, we can see the range of motion of the patient. The mean range of motion can be seen through Wishkar box graph for the quartile range 2 weeks, 6 weeks, 3 months, and 6 months. For wrist pain, we can appreciate that there is no significant difference between both the groups throughout the follow-up. In mean grip strength, apart from 6 weeks, no significant difference could be observed. In the 6th week, we can see slightly higher grip strength in group A as compared to group B. That is for no significant difference could be observed throughout the follow-up. Our study detected some significant difference in pronation and flexion range of motion of wrist at 6th week as well as in grip strength. Otherwise, no significant difference. Other scientists like Swigert et al., Tosti et al., Jiang Span et al. Found significant similar results in their studies. On conclusion, pronated quadratus repair after volar plating in distal radius fractures, it can provide early return to wrist range of motion and grip strength. However, in long term, no significant difference could be appreciated. Thank you.
Study period, 2 years or 1 year?
Sir, 1.5 years.
Study our 1.5 years.
So you concluded that after repairing the pronatus quarters, your result was a bit better.
That's
6 weeks follow.
Otherwise, in later, it was
Almost same.
almost same result.
Okay. What is the function of pronatus quarters?
Pronation of the forearm in a full flexion of the forearm.
At which joint does this pronation happen? Which is the joint which is involved in pronation of the forearm?
The radio and
Which, proximal or distal?
it happens in the proximal radio.
So other pronator of the forearm is?
Pronator teres.
Which is more important?
Pronator teres is more important.
How you reinsert the contracted, what it is, or where you attach it?
Sir, during the dissection only, when we expose the pronator quadratus, we do a sharp, we give a sharp incision over the insertion of the pronator quadratus at its radial edge, and we tie vital sutures on both the ends of both the cuff of the pronator quadratus, and later on we attach both the
Bone is for the really bone attached to the bone, relieve the bone.
A small cuff of pronator quadratus muscle.
You left.
Thanks.
Okay, next. Anyone else?
Yes.
How many more speakers in this session? Yourself. You're the last one. Please. Two more. Okay.
Good afternoon, all of you. I am going to present my paper to evaluate result of GS in the management of resistant clubfoot, a series of cases. Resistant clubfoot are classified when child has had consecutive clubfoot treatment but foot has not corrected. The goal of any treatment is to reduce or eliminate all the components of congenital clubfoot and obtain a cosmetically acceptable, pliable, functional, painless, and planted foot. Over the years, many different forms of treatment ranging from gentle manipulation, anesthesia, severe plaster correction, and forcible manipulation, including the use of mechanical devices for surgical correction, has been tried. Joseph's external installation system is a simple, versatile, and light system. This ensures proper control of all the components of correction by causing actual physiological lengthening and histogenesis of soft tissue. It reduces the pressure on going physis. It was a prospective study that was conducted at our Department of Orthopedics, Paternity College. Duration of study was from October 2022 to October 2023. A total 8 patients, 6 unilateral and 2 with bilateral foot, taking total 10 fits including in our study. Pyramid scoring was used for assessment of the cases, and for post-op correction assessment, we used Hospital for Joint Disease of Paternity Institute functional rating system. Instead of pyramid scoring, it has mid contactor score, hand contactor score. It's invented here, and this is the rating system which is used for post-op correction. We included those patients who underwent consecutive treatment but who has not corrected, that is the definition of resident disease, and the patient of age group 2 to 8 years. We excluded those patients who are less than 2 years or more than 8 years, and patients not fit for surgical procedure. These are components of frame. We have in this JS, J rod, L rods, distractors, connecting rods, and cables. This is a construct of JS. It has TG component, plane component, and metatarsus components. Distraction started on second post of day. There is requirement which has to be turned 20-hour distraction. Medial distractor and distracted 1 hour per day, varying to 490 returns. Lateral distracted 0.5 hour per day and 290 returns. The sector was retained for a period of twice the distraction period in order to allow the stretched ligament and capsule to heal. This is the important thing. Once the fixator was removed, above knee cast was given for the foot in maximum adduction and dorsiflexion.
This is the breakout of all the patients which were included. Total 8 patients with 10 feet in the study, 2 to 4 year age group. 5 patients with 7 feet. Because those 2 patients with bilateral foots were included in this 2 to 4 year age group. 2 had excellent result, 5 had good result, and those who were 4 age group, 3 patients with 3 feet, they had fair score. This is the video picture to get push-up correction, follow-up cases. This is the terrific angle. This is the second post-up, second cases. Conclusion: the JS operator is a simple, versatile tool that doesn't need any image identification and complicated instrument for functional distraction. Currently, pick up the distraction method and follow protocol. Team traces need to be carefully maintained before removing the JS, and enough static phase is required. Strict follow-up and post-op management are required. Differential distraction using JS enable long-term maintenance of correction and good function. And differential distraction technique gives good result in racing cases, but results were excellent in younger children. That we have seen already.
JS का full form क्या है?
So Josie's external extraction system. Josie's external extraction system.
इसका principle क्या है?
So it works on the principle of ligamental axis, differential distraction and ligamental axis histogenesis principle.
Histogenesis या
Histogenesis.
Good afternoon, sir. This is Dr. Chetan, second year PGT NMCH. I am here for my paper on comparative study of post-operative outcomes of clavicle mid-shaft fracture treated by nailing versus plating. Fracture of the clavicle are very common, accounting for 4% of total fracture. The middle third is most common because it does not have any muscular or ligamentous attachment on it. Traditionally, mid-shaft clavicle fracture are treated non-operatively. However, they have been associated with high non-union rates and poor compliance. So we are shifting towards surgical procedures. Two of the most common surgical approaches that we take these days are open reduction and internal fixation with pre-contoured blade and intramedullary nailing using a TENS. This study aims to identify a suitable treatment for mid-shaft clavicle fracture. A retrospective comparative study was done at NMCH orthopedic department between January 2023 to December. Pre and post-operative assessments were carried, statistical analysis was performed, and investigation was done through X-ray, AP and lordotic views. Additionally, CT and MRI was also done when it was needed. We included the patients from age 16 to 60 years, having mid-shaft clavicle fracture, patient with both bone shortening, overriding of bones, or bilateral clavicle fracture. Then we move to operative procedures. Plate fixation first under GA. We give a transverse incision. You can clearly see the fracture site, which is opened. After some tissue dissection, fracture was reduced with a small fragment locking plate, and it was fixed with anterior superior on the anterior superior surface of the bone using bicortical screw. The fascia and skin was closed. Next is nailing. In nailing, what we do is we firstly find sternoclavicular joint and we palpate it and demarcate a tiny incision, 1 centimeter incision. Then we use the awl to sharp pointed awl to open the anterior cortex through which TENS will be introduced. And nailing was done. In follow-up, we followed patient for 1, 3, and 6 and 12 months. They were given simple slings. Pendulum movements were started. There was no weight bearing allowed. Intraoperative and post-operative time, length of incision, blood loss, everything was noted. We saw that almost all the fractures got united within 6 months, with few complications like superficial infection, which was treated later on. There was some in plating group. We saw there were some complications like ugly scar, implant protuberance. When we discuss this, you can see there are 3 X-rays: pre-op, immediate post-op, and follow-up after 1 year, which clearly shows bone union. This is a plating method, and you can clearly see the range of motion after 1 year, which we have achieved. This next we have done through nailing. It also shows pre-op, immediate post-op, and post-op after 1 year. So finally, we conclude that plate fixation as an overall surgical intervention tends to have several implant post-operative complications, including blood loss, infections, implant protuberance, scarring, and longer operative time when compared to TENS. Regardless of any significant difference between TENS and plate fixation, considering the secondary outcomes of early recovery and minimal complications, TENS can be preferred treatment of choice for managing mid-shaft displaced clavicle fractures. Thank you. Patients with mid-shaft clavicle fracture with greater than 2 cm and age criteria was between 16 to 60 years.
जो क्लैरिटी फिक्सेशन का कोई क्राइटेरिया में फिक्स नहीं करेगा, जो क्लैरिटी मोस्टली कंजर्वेटिव जाते हैं, ऑपरेटिव का क्या क्या क्राइटेरिया है?
एक तो सर डिस्प्लेसमेंट 2 सेंटीमीटर से ज़्यादा होना चाहिए, एंगुलेशन शुड बी देयर मोर देन 20 डिग्री,
सब कुछ होगा। इसे भी तुम लगा दोगे फिगर ऑफ एक बैंडेज आ जाएगा।
Communicated fracture.
Displacement more than 2 centimeters. So what is the criteria for measuring the 2 centimeters? In what direction the displacement should be? It should exceed more than 2 centimeters.
Displacement between two fracture ends. That we see in AP radiograph.
Just by simple bracing, will the displacement not come back to position?
It may come, but it may get malunited.
No problem.
For fixed correction, we are going through this surgical approach.
Because most of the indications for surgery is either you have a segmental bone loss, you have got open fractures,
yes,
bilateral clavicle fractures.
Neurovascular injury, clotting or
These are indications, usual indications. Otherwise, most of the practice are being managed by non-operative methods.
Yes.
So, did you get a proper consent from patients regarding this operative intervention?
Yes, sir. They actually, few patients actually wanted to get operated.
So, what was their indication from their side? Why they wanted this open method of treatment?
They could see the prominence of bone in that fractured side, so they did not want that. So they went for surgery. Thank you.
Good morning everyone. My name and I am going to present management of distressed radial neck fracture by metallurgical technique by elastic stable nail. Introduction. Radial neck fracture is very common in pediatric children and treatment varies according to displacement, degree of angulation and skeletal maturity. On distal lesion 30 degree angulation, we can go for conservative treatment, that is long of cast, and displaced greater than 30 degree angulation, we can go for surgical treatment such as percutaneous pin insertion, elastic stable inflammatory nail, and open reduction and internal fixation. Disadvantage of open reduction: it can increase the rate of avascular necrosis, as radial neck in children is entirely cartilaginous and blood supplied primarily from metaphyses that which interacted during fracture itself an open reduction, and premature facial arrest leads to cubitus valgus deformity and it can cause a loss of motion. Material result. It is a prospective study done at NMC Sparta. 10 patients was followed up between 2021 to 2023 period. Inclusion criteria: recent closed fracture, displaced radial neck fracture with angulation 30 degree, children with open closed blade, less than 16 years of age. Among 10 patients, 6 are boys and 4 are girls. According to it, included 7 patients are type 3 and 3 patients are type 4. Metageo technique: retroinsertion insertion of intermedullary nailing and intermedullary pinning insertion using elastic nail that involves a nail across the fracture site. After that, fracture is reduced by rotating the nail. And this is a feature prerequisite. Reconfigure the first 5 cm of nail at it enhance reduction of the displaced radial head and neck. Produce the sharp tip by cutting the inner end of the nail that facilitated entry into the hard bone of epiphysis. Depending upon the age of the patient, we can use 1.5 to 2.5 millimeter nail, and the distal epiphysis identified by image intensifier, and we can place the awl directly into the bone and perforate the near cortex. And after the medullary canal reached, lower the awl to 45 degree to the shaft axis and advance it with oscillatory movement. A short working length, that is 3 to 5 cm between the entry point and the inserter, removes control of length during insertion. Manual direction and direction of length. Point the nail tip to the radial head and try to engage to the head. If the radial head displacement not allowed the nail tip to advance into the head, try partial reduction of the head by traction and manual pressure by harass stress. If it is not successful, remove the nail and recontour first 5 mm more pronounced and again inserted it. Percutaneous K-wire reduction. If manual reduction and recontouring it is not successful, use blunt end of large 3 mm K-wire to push radial head into the partially reduced position. After that, turn the nail clockwise for right arm and counterclockwise for left arm surgeon to reduce the radial head and then cut the nail near the bone and paint the nail. Post-operative period, we give a good antibiotic coverage and slab for 3 weeks, and then patient follow-up every month for 3 months and every 2 months for 3 years. This is the case 1, decorative fixture. And immediate post-op X-ray, and after 3 months, this picture shows complete immune, and this is the 3-month range of motion of this child. And case 2, 10 years male patient with Boacon ulnar radius fracture, and this is the immediate post-op. And conclusion is it is the best method for management of radial neck fracture for child in tracheotomy.
तुम्हारा सीरीज में कोई कॉम्प्लिकेशन होगा?
Yes, sir. One patient showed superficial infection, and one patient, 3 patients showed non-immune, and after waiting for 1.5 years, we can see the immune happen to this patient. And 7 patient shows complete immune.
इसमें कॉमन कॉम्प्लिकेशन क्या है?
Sir, it is as it is a closed reduction, there is no soft tissue damage, so the chances of complication is less in case of metageotomy.
इसमें epiphysis को स्टेट्स बंद कर रहा है.
Yes, sir.
Epiphysis damage.
Yes, sir. That's why you can use CM to see the distance.
Epiphysis के डाल जाएगा. Epiphysis damage होगा तो उससे क्या होगा?
Sir, deformity हो सकता है, sir. Yes, sir.
So you have put all the nails for that was a retrograde map.
Yes, sir.
From distal to proximal.
Yes.
So the third case which you showed, there was a wide displacement of the proximal fragment under the neck of the radius. How did you manipulate it for reduction?
We can first we give slight traction, and harass stress, and we put the thumb to the radial neck for manual reduction, and after the traction and counter traction, the head is reduced in the semi-reduced position. We can achieve that.
Okay, so in almost, as sir said that in almost all the fractures you are going through the physis. So there's always the possibility of damaging your physis. So in how many cases did you face that complication of physeal damage?
Sir, about 10% we do the metageotomy technique, but there is no such complication of deformity around the 2 years of follow-up.
Okay.